Good morning, all. A very good morning on Sunday morning. A warm welcome to all of you. So it gives me immense pleasure to welcome you to this Pedia Connect conclave, which was conceptualized by West Bengal Academy of Pediatrics with support from IAP UK branch and Helion. Let's go for our inaugural function and lamp lighting first. I invite all the esteemed dignitaries for the lamp lighting, Dr. Abhay Shah, Dr. Atnuda, Dr. Chetan Trivedi, Dr. Mitul, Dr. Angelica, Dr. Sandeep Trivedi. Please join us on stage. Holy Dr. Manish. Wow. Myself. Thank you all the dignitaries. Now, the official welcome by Helion. I invite Mr. Venugopal. Please join.
Thank you. Good morning, doctors. Myself, Venugopal. I am Regional Expert Activation Manager, taking care of all such medical academic related programs and representing Helion. So it's a privilege to host you today. And Pedia Connect is a multi-city scientific initiative brought to you by Helion, specially designed to foster meaningful academic exchange and strengthen clinical practice among pediatricians across India. Our vision is to serve as a dedicated platform for focused scientific deliberation, bringing together experts and practitioners to discuss practical evidence-based approaches to common and challenging pediatric conditions. So we have a packed and insightful scientific program ahead of us today. So thanking you all for being here to contribute to this collaborative environment. I'm just handing over the stage to the doctors. Thank you, ma'am.
Thank you, Venugopal sir. So, the most common condition in pediatrics, or I think everywhere, fever. And for fever, we have our expert moderator, Dr. Chetan Trivedi. नाम ही काफ़ी है, अमिताभ बच्चन जैसी personality है. So, fever management in office practice. Dr. Chetan Trivedi, senior pediatrician and ID consultant who doesn't need any introduction in the Ahmedabad, in Gujarat or even in India, now outside also, beyond the boundaries. એટલે બિયોન્ડ ધ બાઉન્ડ્રીઝ, હવે મારાથી બધી કન્ટ્રીઝ નહીં કહેવાય. I also invite Dr. Abhay Shah sir, senior pediatrician and consultant. Sir is guide to all of us, and whatever I say is less for him, but very widely recognized in child health, vaccines, infectious disease, pulmonology and community pediatrics. Dr. Mitul Jasani, owner and medical director of Alpa's Children Hospital and also Alpa. So, practicing pediatrician with over a decade of clinical experience in comprehensive child healthcare, at present President AOP Ahmedabad also. And gorgeous Dr. Angelica Mehta, she is at present Secretary AOP Ahmedabad, consultant pediatrician and asthma and allergy specialist. Very nice work in fever and ID too. Welcome all the panelists and the moderator. Stage is all yours, Chetan bhai.
Thank you for that wonderful introduction. And I would like to add in Dr. Abhay Shah's CV that he's the person who made me recognize. So he's now supporter of many of us who have been now seen all across. And philosopher and guide, that's the proper word for him. This is good. It's called open mind. Hello. Because the
Hello.
subject is such that everybody is expert. So I'm just going to moderate this
Yes,
panel.
Yes, yes.
And when we talk about fever, it can be the session for maybe for 15 minutes, or it can be session for 15 days, right? Because fever is everything like bread and butter, rather bread and bread only for us.
Hello.
Okay, so I'm going to moderate this panel on fever management. Now, this is very precise topic. There is nothing very hi-fi, but still very important part in our routine day-to-day OPD. And here it has been mentioned, it's a fever in office practice. So that is what we are going to discuss. And we all are master of office practice, because otherwise we refer the patient whenever, as and when required. And timely reference is more important. It's an art for a pediatrician who is practicing office practice. So that also we have learned over a period of years. So I have learned a panelist, Dr. Mitul to start with. He's been upcoming star. Dr. Angelica, now almost established star, and our guru, Dr. Abhay Shah. We have done many panels on this particular subject also. So we will definitely have fun. So first, I wanted to have a session with a mentee, because I like that question answer session. But I think it's okay. We are almost 40-50 people and we can manage with this question answer thing. So my first question is, what is normal body temperature? What is normal body temperature? And I would like to get answer from you. Who will like to say? Out of this ABCD?
98.5.
Okay, A.
A.
A. Okay, how many for A? Okay, he has changed it and there's no option. So you will like to go for E. Okay, fine. How many for E? None of the above.
Sir, me.
Okay, then 98.7. Okay, Rajesh. थोड़ा आगे आ जा यार. मेरा फर्स्ट ईयर इतना दूर बैठता है, डरता है अभी भी. Oh, that's another interesting question. If you want to admit. Okay, fine. So, Angelica, your quote. None of the above.
I will go with E, 98.7.
There,
Exactly.
he's got a
Yes.
point.
So
Okay,
the
fine.
temperature
Okay,
can
next
vary.
Next question. See, when he says normal body temperature, I would like to say it's a core body temperature. Okay, so that is, let me sir, Amar, tamari paase pachi aao. I'm coming to you. Where I'll get confused, I'll ask you. Now, what is fever? A, B, C, D. What is fever? Tamari baat se jo. Let us get a clue from audience. A, B, C, D bolo na. D. Everybody? D?
D.
B. 99.5. Okay. Now, yeah, okay, Angelica. You
So
can start
according to
with
the
it.
definition of fever, the core body temperature more than 100.4 is fever. So core is either rectal or tympanic.
That will come to discussion later on. Sir, everybody said some figure. What is your call when you talk about normal core body temperature?
So by and large, we use the auxiliary temp method. And when the auxiliary temperature is more than 98.4, I think it is beyond the normal. That is number one. But at the same time, if you look at the core temperature, where the rectal temperature is going to be 0.4 or 0.6 degrees higher than the basal auxiliary or temperature, in that matter, I think 99.4 is a fever.
So what I say is core temperature is never a one figure. It is a range. So whenever I say this is a fever, it is not a fever. It is called a core body temperature. Core body temperature is also 37 to 38 degree. So that is a range. So never a one cutoff. Okay. So that is what is always a range, because of diurnal variation. If you see between 5 to 7 p.m., your temperature will be high. If you see early morning 2 o'clock, that will be at low. So there is a variation almost in the tunes of 1 degree. So you can't say what is the normal temperature. It's a range. That is one thing. Then it varies on age, time of the day, physical activity, whether the like female is it's in menstrual cycle, what is the phase of it? And these are the other things which have been considered to define what is the normal body temperature, core body temperature. Now, when we talk about a fever, as you said, yeah, it is definitely it is increase in body temperature, particularly core body temperature, because it is a part of the specific biological response to which has been mediated and controlled by central nervous system. So now it depends on, so again, a site of measurement, as everybody said, an age. Okay. And fever should always be documented, never by just touching. That is what we want to say. So when you say this, everybody said that yes, if when you talk about say age group, healthy neonate, and say young infant, 1 to 3 months, the rectal temperature. So whenever you want to decide a core temperature, not a single reading is going to be representing core temperature per se. You can be nearer to that, but not exactly, because you can't go in the core and get at the temperature. So that is one thing. And second thing is what sir said, rectal temperature is a bit over the core temperature, while rest are lesser than that. So we don't have an actual cutoff, right? So we have to see where it is measured, how it is measured, and what is the cutoff. So this is a roughly, but what we are worried more about a fever of concern. We are not worried about the temperature per se. We are worried about a fever of concern. And what is that? When you have healthy neonate or less than 3 months, that is a period where we say it is a fever of concern. And otherwise, if it is more than 102, 3 to 36 months, and any children more than 103, this is fever of concern. So there we will try to make the things work, and rather we should be acting. So can you say what is the pathophysiology or pathogenesis of fever? Anybody? How fever comes? Like,
So basically, any inflammation or infection is there, it will lead to generation of interleukin 1, interleukin 6 tissue necrotic factors, which will increase the production of prostaglandin E, which will act on the hypothalamus, and it will raise the set temperature.
so this is what pathophysiology is all about. You have infection, and particularly if you say there are 3 different mechanisms by which your temperature, body temperature can go up. So that is what is that? The pyrogens. Pyrogens can be exogenous or endogenous, and then the whole cascade what he described. Second thing is you can have a heat production which is more than heat loss. This is a situation when particularly salicylate poisoning or malignant hyperthermia that occurs in anesthetized patient, and defective heat loss, like there is ectodermal dysplasia. So the heat loss is defective. There it can cause a fever. And what exactly he explained is infection endogenic pyrogen. The pyrogen will liberate the cytokines, and particularly interleukin 1, that will go to hypothalamus, will cause PGE2, and that will elevate the thermoregulatory set point in hypothalamus. So we have certain thermoregulatory point. It goes up, so the body mechanism start working on increasing the temperature of the body. And that is all about physiological pathophysiology of fever. Now, 5-year-old boy presented with fever 106.8 in the month of May. What will you do? A, B, C, D. What will you do? What is? D followed by. So first you will give cold water spread and fanning. Followed by that you will give paracetamol. Okay. Anybody?
We'll see the history. The history of like sunlight.
This is what. Yeah. Okay.
Yes, definitely.
This is in the month of May.
But we can also have infectious fever.
One-
If there is history of outside exposure, definitely.
Correct. Okay. Angelika, you can take it.
Yeah,
But so
so
what is it exactly?
this is basically external exposure to exogenous heat because of maybe heat stroke in the month of May. So the mechanism here, this is called hyperthermia.
Okay,
so what is- yeah.
that hyperthermia?
So hyperthermia is basically there is no change in the hypothalamus set point, and it is not because of pyrogens. So your antipyretic has a very limited role in this. The external cooling measures are more important. So fanning, giving cold water compresses is the mainstay of treatment. Yes, as Dr. Nishal Bhai said, yes, you can give paracetamol, but after all these measures are done. So the primary treatment will be external cooling.
Will you give paracetamol in this patient?
It is not going to work, but we definitely give it practically. It is not going to
Why
work.
it is not going to work?
Yeah. So as rightly mentioned, there is difference between hyperpyrexia and hyperthermia.
Correct.
When there is a fever, the prostaglandins are involved, cytokines are involved, and they will going to raise the thermostatic temperature set point in the hypothalamus. Now, as far as this hyperthermia is concerned, maybe because of anesthesia, maybe because of heat stroke, or maybe endocrine, whatever cause, the hypothalamic set point is non-involved. And therefore, the prostaglandins and cytokines are not there. And since the cytokines are not there, your antipyretics are not going to work. So this is very important. So here, the cooling, fanning, and physical methods are going to be there. Of course, we do not dare to not to give the paracetamol. We give it, but ideally, it's not going to work.
So point is very clear. When it is a hyperthermia, it is a body temperature which has increased without change in thermoregulatory set point. What paracetamol does, it brings down the thermoregulatory set point to lower level. And that's why the body will act accordingly and gradually temperature will fall. But in hyperthermia, because it is not been changed, your paracetamol may not work. So when there is a fever is very high. That is hyperpyrexia, where the thermoregulatory set point has been gone up. So what body has decided, CNS has decided, hypothalamus has decided that I'll keep it 102. So what will happen? Body will start generating heat. They'll start conserving the heat, and there will be vasoconstriction and there will be heat generation. So if you bring it down, then it will work if it is a hyperpyrexia. This is very important.
And this type of hyperthermia is quite common in the athletes. They suddenly shoot exo 106, 107 fever after strenuous exercise. And that is going to be very dangerous because there is massive tissue necrosis. There is myolysis, and it causes hyperkalemia, acute kidney injury, and even acute liver failure in no time.
So what sir has told is a typical heat stroke, which is an exertional heat stroke. There are two types of heat stroke. One is classical. When you get exposed to external heat and it will be drying, there won't be perspiration and there will be high fever. That is heat stroke classical. What he said is exertional. After exertional, there will be increase in body temperature, and that is what all complications are expected. So now next question is, as we discuss everything, it is both there will be fever which is very high grade. Only difference is because of this change in the thermoregulatory set point. So this is what I'll just like to explain. Euthermia. Your thermoregulatory set point is 99.6, okay, 98.5, whatever, normal. So this is normal. Now when there is a fever, your thermoregulatory set point goes up. So what happens? Body will try to reach to this particular thing. If you give any antipyretic, this will bring down, and that's why the fever will come down. When heat illness is, what happens? This is almost same. Fever is there, but thermoregulatory set point is here. See, O and O here, but the temperature is here. So your PCA will not work. This is a very important fundamental difference between euthermia, fever, and heat illness or heat stroke. That's very important. Okay, now as we discussed, what are the causes of hypothermia? What I think one is heat stroke.
Then post anesthesia, then salicylate poisoning, and endocrine like thyrotoxicosis, pheochromocytoma,
these are
and
the
most
four
important, pontine hemorrhage.
Yes.
Pontine hemorrhage, that is very important as far as, and any tumor in the hypothalamus. These are causes.
So these are the four major groups: environmental, drug-induced, medication, and pediatrics. Like that are overlapping of. Sometimes you have been over close. I've been there. It has been most commonly what happens. The parents have gone to do something shopping. Child is inside the car and glasses are up, and by a chance that AC is not working. That is a thing which has happened many a times. Small little boy, child remains in the car. So that is again is the hyperthermia. Okay, now is it required to document the temperature in fever cases? Yes. Document. Will you like to ask to measure compulsorily? Which are the situation when you say now I want a documentation and proper record of temperature? Which are the situation?
I think it's universal. Everyone, it should be always documented. And
Document is fine.
serial
Once you have
record
documented,
is
serially
serial
recording-
record is important, not a single reading.
So which are the situation in our practice where we will say, no, I have to see the temperature?
So infants less than 3 months, because
Very
they're high
important.
risk. Then whenever there's a
Why
history,
infant less than 3 months?
because they can have a severe infection, like
bacterial infection.
septicemia is very
Correct.
common, and it can be unrecognized because it can be subtle.
Fever
Then
can be single most symptom
symptom.
which causes a severe bacterial infection.
Then
Okay.
whenever there's a past history of any febrile seizure, then that also becomes an important thing.
So practically to differentiate febrile seizure from the epilepsy, we can say, okay?
Then when there is an unexplained, when the fever is the only symptom and there is no other symptom associated, like fever without focus. So malnutrition,
immunocompromised child.
malnutrition.
Now, when we talk about fever, we just measure fever. We just let us take temperature recording is important. Which are those situations? Temperature regulation, measurement. Hypothermia.
Hypothermia, even newborn baby, immunocompromised child, because they do not mount that good febrile
Very
response.
true.
So even a 98.4 or 99% in a not good looking child is going to be worrisome. And secondly, the new fever onset in the ICU. That is very important. Child must be recovering from the dengue, but again starts even 99 fever. I am worried because maybe thrombophlebitis can be initial of the HLH, something like that, or secondary sepsis by gram. So new fever onset in ICU is very, very important, even if it's 99. Similarly, low grade fever in newborn, low grade fever in immunocompromised child, all is the worrisome.
Right. So just to complete the list, shock. We know there is a difference between the core body temperature and a peripheral temperature. So that's why we do it. And most important, hypothermia, drowning and newborn. These two are the conditions where should be recording the temperature. May not be fever, but still temperature recording is important. Okay, now what is the fever of short duration? I think we discussed is age less than 3 months, then for malnutrition or in immunocompromised host. These are the three situations where I think even in a short duration fever, it is very important to document and measure it. Okay, now, yes.
One important epidemiological clue here, that when the child has the fever and in the same family or in the vicinity, when there is unexplained death because of the fever, I think it is very important from the epidemiological point of view.
Very true. That history is very important. We should be very alert. Now, Mitul, fever is friend or foe?
It is both.
Okay.
It is friend in one part also, and it is a foe also.
How it is friend?
So because it will gives us a symptom.
No, maru jyoto.
Acha, okay. So because it will show us a symptom that the child is sick, it will represent that. Even intensity of fever will alert us how severe may be the sickness in certain conditions. When it comes to foe part, it will cause dehydration, it will cause dullness, and invariably a dull child will be taking orally less and may get less energy. So excessive energy loss is there through fever, and less energy is consumed. So that way it will be acted as a
Anything you
foe.
want to add? How you
I would-
convinced your
yeah.
parents to?
That when you have to be concerned about it, like the child is drowsy, passing less urine, vomiting is there, breathlessness is there, we tell them all
Red
the red
flags.
flags. Yeah. And otherwise, if there's a mild to moderate fever, child is well in between the febrile episodes, taking orally well, passing urine, there's no need to worry.
So, otherwise, immunocompromised host will not mount the fever. That's why we are worried that they will not mount a fever. So if your immunity is working, that means fever is coming. So that's a good part of the story, I can say. Sometimes, acute fever, we have to explain them. Your child's body is very strong immunity. That's why it is giving very high temperature. So suppose we are fighting, if I am not strong enough, I'll not resist. If I am strong, I'll hit you. So that's why we can explain at least for 1 or 2 days of fever when we know that it is not the real concern. So need to treat the child as Dr. Angelica said, you have to see as a whole and not just the number. Okay, now this is a simple case scenario. 3-year-old child brought with a complaint of fever, high grade, since 1 day. Parents are very much stressed and they said it is not coming down with, or rather not responding with fever. I'll share the prescription, what routine prescription we have in our OPD. Can you see the prescription? I'll just read it for you. He started with azithromycin, added Meftal P because not responded to paracetamol, and because it was very high grade, added investigation. Is there any error? Everything is full of errors. So this should not be our prescription. Date is also not correct because we don't know it is 2025 or 26. So everything is wrong about it. I can't share anybody's prescription. That's why I made this prescription. That's why I tried to make everything false. Okay, so what will be your approach in this patient, sir? Starting from beginning, I'll just...
We discuss it so many times, but still we see number of prescriptions like this.
Correct.
So this is a very sorry plight of efforts, number one. So in an otherwise immunocompetent child, when there is a fever on day 1, I think you need to devote quality time to parents. Number one.
Can you be very sure it is a fever or not?
No, we have to measure it. First thing, we have to measure it.
First, you will like to...
You have to measure it. We have to confirm that the child is fever. We will not go just by the history. But by and large,
documentation fever is important, you said.
very important.
So how will you ask them to document a fever? Suppose if you explain them, what will be your
No, when the child comes to us, our staff nurse may take
Suppose
them.
at that
but
time fever is not there. It is
Otherwise, any febrile child, any parent should be educated how to take the proper temperature. That is number one. By and large, auxiliary temperature is most comfortable. So, and number one. Secondly, said once the fever is 100, 101, 100, whatever is number is there, look at the child comprehensively. How the child is comfortable, whether the eye contact is not there, whether the child is taking feeds well or not, is there any vomiting is not there, if it's passing urine there. So all these factors are very, very important. And in that basic situation, if the child is well looking, if he is responding there, it can be consoled easily. And probably a simple dose of paracetamol when the temperature is more than 100, or if the child is very cranky, in that case, paracetamol, and ask them to wait for at least 4 to 6 hours. Do not just go on repeating the X. But on the other hand, if the child is drowsy, even if the fever is 100, but the 104 fever, child is active, playful, making eye contact well, taking good interest in the surrounding, I'm not worried. Another child, 100 fever means moderate fever, but the child is toxic, vomiting, everything. Do not have that healthy eye contact. I am worried. So this child definitely needs some observation. May not have upfront start the investigation or antibiotic, but this child requires an observation. So these two things. So red flags are very, very important.
Perfect. So you have to see as a whole, not just the fever, but you need to explain them what is the documentation of fever. My question is, ask them how they have measured. Because many times they say fever, high grade, but they have not measured. They have might merely touched that. And interesting fact about touching is this is a worldwide, the most commonly and frequently used technique to measure the fever. And there is study which shows that 80% of time, when the parents or a mother, they tell that it is a fever by touching the baby, it is correct. So sensitivity is 80%. But when it comes to medical or healthcare professionals, it goes down to 42%. So it is having a positive predictive value, not a negative predictive value. So if they say fever is there, mother ko lagta hai, then 80% chances that it will be fever. So that is again just a discussion. But now, I would, yes.
At the same time, AAP recommends the American advantage. When the mother says the fever is there, we should not ignore it. That is a clear recommendation.
So that is a positive predictive value that there is to be some fever. So they may not say temperature, what is temperature, but fever is there. Then you have to document. So my question is, I'll give you 5 options. which is the site of fever measurement which is most close to body temperature. Now we have just seen everything: axillary, oral cavity, skin. We have that gun also, and there is some strip also. Ear canal, infrared emission detectors, and rectal. Which is closest to body temperature? E. Anybody other than E? Also or only? Anybody for D?
Yes.
Yes. So panelists are going for
So rectal is the most appropriate as far as core, but it is very cumbersome, not practical to do everything.
okay. Just tell me
So-
advantage and disadvantage of rectal measurement.
No, rectal is troublesome. Child become very irritable. Sometimes there is chances of injury over there, and it's very difficult to do the rectal temperature. So even in the nursery, where they are keeping 600 gram baby, they do not measure it. So it's a once in a while in a very septic child you are suffering really from hypothermia. Once in a while, but not for the fever. It is mainly for the hypothermia
Correct.
in a very septic child who is very low birth weight. Otherwise, for a fever management in office practice, there is no role of the rectal temperature. And second thing,
No, I'll come to that.
second thing, as far as tympanic membrane temperature.
Sir,
is-
1 minute.
Okay.
Let me finish the rectum part, then you take tympanic. Rectum, the problem is because it is going to measure the colonic temperature, right? So colonic blood supply is such that it takes time for equilibrium. So if you have started the measurement to reduce the fever, there will be a lag of say 4 to 5 minutes. The temperature will show wrong. So that's why it is very important, very urgent to measure temperature, particularly in hypothermia, drowning. So if you take rectal temperature, it will give a false reading, right? That is one thing. Now, sir, go for the tympanic membranes.
Yeah.
In NICU, which is the most reliable as far as they say, because environmental temperature is controlled in NICU, axillary can be better. Because rectal, there are chances of infection, there are chances of injury 1 in 1 million, but still it is a remote possibility. That's why it is not been used much. But in NICU, control temperature, you can have this. Okay.
So as far as the tympanic membrane is concerned, the temperature which is measured by this at the site of tympanic membrane is usually estimated to be equal to the blood bathing the thermostatic temperature in the hypothalamus.
Yes.
So that is why it is near to the core temperature. But at the same time, the values of this tympanic membrane temperature has not been standardized, not in the children as well as not the adult. So I think there is some, we look for the more data, but this is going to be the order of the day.
Yes.
As far as time passes, in the next 3 or 4 years, probably we'll forget about axillary or temperature and we'll go for the only for the tympanic membrane.
Yes.
Yeah.
Also, one advantage, even if the child is crying or there is wax or otitis media, it will not interfere because it is because of infrared emission detector. So
what
all these
it
3
measures-
conditions will not affect.
What it measures? Infrared, it's a heat or thermal, whatever comes
Coming
out
from
the
the-
heat from the tympanic membrane, it measures.
Yeah.
So thermal emission has been measured. So you have to direct it towards the tympanic membrane. So if you have by chance directed to ear, external ear, it will give the external recording. So that is important. It has to be exactly targeting your tympanic membrane. Is there any chances of damage to tympanic membrane? No, not really. Acha, is it possible to use it in less than 2 years? No, because the size is minimum is 8 millimeter. So that's why sir is telling it maybe in order of day, maybe in future, if you get a smaller size, these thermometers, and the thermometer which will tell you that now you are at properly targeting the tympanic membrane, you are at proper distance from tympanic membrane, there is a green light, then it will be measuring, then it is the ideal most.
Right. And then in cases of autoria also, there is going to be some problem.
Yes. So your thermometer will not go inside. So that is fine. So what about this skin temperature?
So we have used it in the COVID time, but now
Yes.
this is mainly for the screening purpose.
Right.
Means that if the 10 children are coming to you, you have to screen it. And those who are having fever, you may isolate. So this is not for ideal, typical fever management, but it's generally for the screening purpose.
Oral cavity, Mithul, will you like to go for oral cavity measurement?
Oral cavity measurement, it can be used in children above 6 years of age who are cooperative, and 2 main things will to be informed. The child should not have consumed any hot or cold drink before taking the temperature within half an hour.
Correct.
Otherwise, it will give us a wrong false positive. Or
So
negative result.
oral temperature takes the lingual artery temperature. You have to keep it below the tongue. And I think less than 5 years now, child will be able to do it and they will chew it. That's why mercury thermometer has been banned because of breakage issue. Now it is digital only to be used only after 5 years. Now, most commonly used by all of us is auxiliary. Pros and cons of auxiliaries. What are the advantages and disadvantages? And fallacies rather.
Advantage is that it is easy to
Easy.
measure and it will give a good reflection of the fever. I think more than 99 is the considered as the cutoff for fever in auxiliary temperature. Cons, I don't think there are any. I feel that it's a very convenient way.
Environmental temperature. Most common is because if the child is staying in AC,
Okay.
similarly skin
So it
temperature,
can-
ear temperature, it will be.
Affected by environmental temperature and bathing also.
And most importantly, when we ask them, just look at the method because they'll put it like this, and this tip will be outside.
Yeah, technique has to be
This
proper.
is wrong technique. Correct.
Yeah.
This is wrong. What is the correct technique?
Vertical.
It should directly go into apex of the axilla. So that is very important. You have to show them. Otherwise, all the time they'll be putting like this, and it will
And
be
the
reading.
tip visually projected outside.
So AC temperature will be given. Okay, fine. So these are the different, but as the sir said, the most nearer to core temperature is tympanic membrane because the supply of tympanic membrane through carotid and hypothalamus also through carotid. So hypothalamus is bathing in the same fluid which has been giving the heat to the tympanic membrane. So it can be most nearer to the core temperature. Now let us go to this. What is the recommendation? You have two recommendations, NICE guideline, another Canadian. Both guidelines are confusing, but what we can take is this Canadian is better. But to 2 years, rectal definitive measurement, auxiliary only for screening. So whenever you want to document the fever, it is always your auxiliary screening, but rectal is confirmatory. Okay. 2 years to 5 years, you can use rectal, tympanic, and auxiliary. Above 5 years, oral can be used. So in general, less than 5 years, no oral, no rectal. Right? Above 5 years, anything can be used. And if it is less than 3 months, then you can definitely go for auxiliary if it is in NICU, otherwise rectal. Okay, fine. Now let us go to another question. Then in this case, Mithul, will you give antipyretic? This patient which was having high grade fever, you ask them to document, they were documented 103 fever. What will you do? Will
Yes,
you
sir,
treat it?
I'll give paracetamol antibiotic.
Okay, so first question was, will you give it or not?
Yes.
Okay, so what is your indication of giving antibiotic in this?
Sir, any child who's having a fever is creating discomfort to the child,
Is it necessary to create a fever? 101 fever child is playful. What then?
then you can avoid it.
Yes, so fever just a temperature measurement cannot be the reason to prescribe antibiotic. Fever affecting its routine, rather to make them comfortable, we give antibiotic. That's a basic rule of antibiotic. Otherwise, we will fail miserably because they will be measuring 103. After that, they'll say there is no response, 101 only. Then, so if the child is comfortable at 101, then we don't have to treat it. That's a basic reason. Now, choose between. Will you choose paracetamol exclusively or you use ibuprofen, mefenamic acid, nimesulide? Which will be your choice?
Okay, so paracetamol is the time-tested, universally recommended antipyretic of choice across all the ages. It is very safe, has a very good therapeutic index. So I will always prefer paracetamol as far as possible. Second line, I may use ibuprofen in some selected patients, but you have to make sure that first the age, it is not recommended in less than 6 months. So I will not use in that category. If there is a dehydration in a dengue patient, if there is a history of GI, especially because it causes gastritis in GI disorders, I would like to avoid, even in renal. So we have very few indications, renal, and then also one important place where we should not use ibuprofen is varicella, because it can cause Reye's syndrome. So it has a very narrow, range of
Safety.
recommendation. But yeah, I do use it in my office practice, especially whenever there is a risk of febrile seizure, I do use it.
Okay.
Some patients when there is very high fever.
Bye. Now patient is telling I have given paracetamol, fever is just coming down little. Should I use some other
So-
antibiotic?
Paracetamol, paracetamol, paracetamol. That is number one. Dose is 15 milligram per kg. Can be repeated 4 to 6 hourly. And in spite of this repetition, child drug is absolutely safe, and that is the beauty of it. So even what Dr. Chaitanya said, that if the child fever is not coming, you may give little single extra dose also. This type of luxury is not available with other antipyretics, including mefenamic acid. We said mefenamic is safe, and the ibuprofen. Now look at the dose. As far as the ibu and methadose is concerned, they are 5 to 10 mg or 7 to 10 mg per kg, respectively. But in a dehydrated child, where the child has got high grade fever, where the oral intake is going to be poor, at times child is having a vomiting. There is a totally already dehydrated. It may not be clinically obvious in an older child, but when the dehydration child is at the same therapeutic dose is going to be toxic because they directly affect the liver, they directly affect the kidney as well. So as far as therapeutic window is concerned, is very wide for the paracetamol, and it is not with the other two drugs, NSAID. Now, second, let us look at the efficacy. So there has been a 10 RCT and 9 non-RCT studies, and they have studied nearly more than 2.5 lakhs children. And what they have observed that ibuprofen is slightly more efficacious for reducing fever at 4 hours and at 4 to 12 hours. Means after 12 hours, the effect remains the same. And if you look at the efficacy, the temperature which is which is responding is by the tune of 0.2 to 0.4 degree, not much more than. So though it's a faster action, though it takes little longer, but by the end of the 12 years, probably they almost remain the same. Number two. So one is safe, other is only slightly more efficacious or slightly more powerful, but is a huge disadvantage of the side effects. And third one, febrile seizure. I think it's a myth. It's myth. It's not that you give the strong antibiotic, it is going to prevent the
Because we are
febrile
not sure
on the
whether
contrary,
this
sometimes
fever will cause a
febrile
febrile
convulsion appears in a febrile child after the fever subsides. So 104-degree fever, you give the paracetamol, you give the suppository, fever comes to 100, and in the hospital,
Convulsion comes.
child throws the convulsion. So it is not that any amount of any strong antibiotic is going to prevent the febrile convulsion. It's a myth.
So basic, very clear. Fever is like 104 to 102 with paracetamol or ibuprofen, both. Because both drug will be reducing temperature to 1 to 2 degree, at the most 3 degree, not more than that. So don't expect once you give the antibiotic and it will come to 98.4. And most importantly, people, they think that 98 to lana hi hai, then only fever is not. No, there should be a fever which should reduce and make the child comfortable. So our goal is not to use strong or weak antibiotic, just to make the child comfortable. So by making this temperature get a bit lower, they will make the child comfortable. So that's why people are thinking that don't ask them to record regularly, because that is the most common cause of fever phobia. Because if I say make a chart, they will measure every half an hour. Every half an hour, fever 104, 103, 103, 102, 102, and then they will keep on calling you. So that's why there's a fever phobia. So rather, don't ask them to measure. Just look at the child, whether it is comfortable or not, and then you manage the patient. So that's why one thing. Yes, sir.
One second.
Yeah, yeah.
So if you have got the pain, probably, I think that ibugesic has some edge over that as far as pain is concerned. So suppose a child has got the dental pain, on fever, child has got joint pain and fever, saying ibuprofen is little more. So for inflammatory purpose. And one study is also there, when you give the 20 milligram of paracetamol, it works better than the full dose of mefenamic acid.
Okay, sir. Now, what I understood is paracetamol starts acting 1 to 2 hours, ibuprofen same. Effect peak 3 to 4 hours both. Effect lasts for 4 to 5 hours or 6 hours for paracetamol, ibuprofen 6 to 8 hours. That's the difference. We should be giving after meal for ibuprofen. Paracetamol can be used frequently. What is the upper dose of toxicity of paracetamol and upper dose of toxicity of ibuprofen?
So upper dose of the paracetamol means up to 75 to 80
100.
milligram, it is safe. But when it crosses 150 milligram per kg per day, it is going toxic. But this level is not upper. What the child actually gets at a given time, and whether this liver is going to metabolize it properly is very, very important. So you can repeatedly small doses, and this is 150 milligram per kg more, it is going to toxic. But at the same time, if you give at a stretch, 1 hourly, half hourly, and it reaches to more than 75 milligram, it can also become a toxic.
So 10 times the recommended dose is 15 milligram. If it is going above 50, then it is toxic. That's why we have very wide range. We hardly have seen the paracetamol toxicity or the poisoning patient. Except one case I have seen, pathologist couple, their child was here, was managed by the grandmother. Whenever there was a fever, she was called and she was saying, just give paracetamol. She used to give 5 ml paracetamol, and that was paracetamol drops.
That is most
So that's why we come to another discussion, we should be mentioning what is the drops, what is the strength of the paracetamol. There are n number of prescriptions like other strength are available. Now, sir, suppose or Mithul, I have a patient with a vomiting. He is not tolerating paracetamol. What will you do?
Suppository.
Suppository. So, have you used the suppository paracetamol? What are the advantages and disadvantages of it?
Sir, advantages are that you don't need to give it injectable to the child.
Okay.
You can bring down the fever with the paracetamol suppository.
How it works? Works
Yeah.
well.
It works well, sir. Almost
Okay.
similar to oral paracetamol. The cons is it's a discomforting procedure.
Okay.
The child may not be able to take it very well. Child may reject
He
it.
doesn't have to take. He have to accept. He has to accept.
Yes, yes.
Yes.
Right, sir. And it cannot be done at home easily with the parents because parent had to be very well trained to
So,
do that.
Convenience is not there, but effect is there, but the absorption is erratic. So that's why sometimes, and any dose difference in that oral and parectal,
Same
same.
Okay.
Okay. So, acha, third one is IV. So IV, parectal and oral. If there is a vomiting, you have two options. What is the indication of IV and whether it should be used or not?
I think the IV paracetamol overused, misused, and disused. And I'm very sorry to say, whenever I go to many nursing homes, probably they give injection febrinil 8 hourly. Similarly, in a dengue child, they give IV cerebral bottle 100 ml, BD over 8 hourly. I think this is absolutely a criminal practice, I would say. So it is not required. It is required in very, very few conditions when you are pushed to the wall. That is very important. So if the child has got severe septic shock, where the fever is 104, 105, and is you know that parectal is not to help, oral is not going to help. This is the ideal situation where I want to give some comfort. I want to reduce the metabolic rate of that particular child. In that case, also. So very few. Similarly, if there is salicylate poisoning, you can give it. But again, their paracetamol is not going to work. And if there is severe body, so it is very, very selective, under observation, under medical supervision, and that too in ICU, it is required.
Yes. Nimesulide and mefenamic acid in your practice, office practice.
I don't use any of them. Mefenamic acid actually is not recommended globally. It's only available in India. So there are no trials to suggest the safety profile. And there is a risk of GI bleeding and also adverse drug reactions. So as far as possible, mefenamic acid should not be used, and never the combinations of paracetamol with mefenamic acid or even ibuprofen with paracetamol.
So there is a difference
So-
between these two combinations. Abhay,
So-
I will just, you
Yeah.
just add on to this.
And nimesulide, though I've not used. I know it's
Why?
hepatotoxic and it's not
It
recommended.
works very
It's
well.
not recommended in pediatric age group. It is only used in orthopedic conditions. That's the only
People are using the
condition in
tablets and
adults.
crushing it and giving it.
Yeah.
So it's,
I have not used
yes,
it.
sir.
So there is a myth that when the child has got the viral hepatitis jaundice, that mefenamic acid is safe.
Yes.
Again, it's a myth. Even in a very bad liver, it is a paracetamol.
That was one of the rapid fire questions for you. Anyway, sir, combination of brufen paracetamol versus combination of paracetamol with other drugs. How will you weigh that?
So no fixed drug combination are to be used. They are irrational totally. So if you want to give the paracetamol, ibuprofen for any purpose, give it separately. That is very important because you are ending. There is 156 milligram of the paracetamol. So you are reducing. You are giving the subtherapeutic dose of the paracetamol. You are not giving the adequate dose of the ibuprofen. On the contrary, you are increasing the side effects and the cost of the therapy.
I think that is true. It holds for all the drug combinations,
Yes.
not only this.
So-
So probiotics, antibiotics combined, levocetirizine and montelukast combined, all are irrational. You should not combine any two drugs together.
So
Even your
never-
phenylephrine, like cold and fever medications together should not be given.
cold cough mixtures. We'll
Single
have
drug.
discussion in respiratory.
Single drug.
We'll have discussion in respiratory.
And one thing I want to add, ibuprofen can also exacerbate asthma. So in asthma patients, it should not be used. It
Okay,
can
that also
trigger
we'll
that.
discuss in respiratory. Anyways, so brufen paracetamol combination, no. Everybody is using plus. Don't use it. Either paracetamol or rarely ibuprofen. That's all. We will end the discussion here. So goal is, as I said, just to make the child comfortable. These are this thing. And yeah, now we have given antipyretic. Any other supportive management you will do? You will advise the patient. That patient has come for 1 day fever. You know it is nothing wrong. It is just a fever. Definitely making discomfort to child. You advise antibiotic. And that will you give it every 6 hourly or SOS?
It's always SOS after measuring. And the other most important advice is hydration. So I'll always emphasize to give enough
How much
liquids.
fluid?
So 100 ml per kg per day, that would be the maintenance plus the losses.
Will you calculate
So-
and write it down in OPD?
I give a rough estimate to the child. You say you titrate with the urine output. So I just encourage the child to take as much fluids as possible so that he's passing urine adequately.
Yes.
That is
there,
how I
there
say.
you are. You
And-
should be adequately hydrating the child to the level that he or she should be passing urine at adequately, maybe 4 to 6 times. At the same time, you try to increase the intake, but you know that because the child is fussy, they are not taking it, the dehydration chances are there. That's why paracetamol makes the first choice. And anything else other than dehydration?
Rest.
Rest. Why rest?
Because it reduces your, what you say, demand to the
Metabolic
body.
rate. So
Yeah.
metabolic demands will be reduced. So again, it will,
child
because
will be better.
that's why it is 4 because it increases the metabolism. Okay. Anything else other than hydration? So we'll do this rapid sponging, yes or no?
Controversial.
Yes,
Okay.
Tapids,
Let Nishal answer. Now he is doing it in practice. So tepid sponging role, controversial or convincing?
For me, it is convincing because it reduces the temperature from the body. It helps in heat dissipation. So it at least make the child comfortable and reduces the temperature. That is what matters.
What will you advise?
Advice will be after 15 to 20 minutes of paracetamol,
Why after 15 to 20 minutes?
because the set point of the
This is very
hypothermia
important.
should come down. Otherwise, body will try to increase the temperature. Child will start shivering otherwise.
So
And
without
it should not be.
paracetamol- Without paracetamol, if you start tepid sponging, it will decrease the body temperature and the body will get signal that body temperature is going down. So again, it will try to increase the body temperature.
And second, it should be normal tap water, not a cold water or ice water, because again, the same thing will happen, that the hypothalamus will get the signs that the temperature is going down, will try to increase. So it is just a simple tepid sponging all over the body.
Afternoon, she called me, tap water. Will you use it or
On May, in the month of May.
Actually, body temperature करता lower temperature वाला पानी.
And then I'll advise mother to remove all the clothes except the diaper or so, and then apply all over the body, in front, back, on the hand, and on the, not only like movie ma batade chhe na, that is not useful.
Don't keep it like that, you have to remove.
You just have to keep on removing it, again cool it, and then
Any role
doing
of
it.
colon water? Beauty colon?
Not much. It should be a simple water.
So first, Abhay, what is the, okay, you want to add something first, you add it, then I'll ask
so
you.
basically what happens is once the set temperature goes down from the hypothalamus, there will be a vasodilation, which will hasten the process of bringing down the temperature. When you give paracetamol, you start tepid sponging with a regular temperature water, and the vasodilation will be hastened up when you give tepid sponging. That is the mechanism what I have read, and that is how it is helping. If you use cold water, it will cause counterproductive vasoconstriction, and then it will not be helping us. That
Okay,
is what it is.
what data says? Tepid sponging works or not?
So it's absolutely controversial. And some of the guidelines suggest that it is counterproductive. You should not use it. There are a number of guidelines which say it. But by and large, what I do, if the child is 104 degree and not comfortable, I give a paracetamol, either suppository or orally. And then I do this tepid sponging. In the winter, even I will use the lukewarm water in the winter, because I want to prevent it. Because the water has got excellent capacity to absorb the heat. And what is more important, that you have to a single layer, not even a 2 layer, because heat is a poor conductor, air is a poor conductor of heat. So if you have layers like this, there is going to be multiple layers of air and cloth side, and your heat is not going to be transferred. So you have to take care of the conduction and the convection both. So a single layer, thin cotton cloth, and put it on the
Exposed.
exposed on the all part of the
All
body, and keep one person to rub it. So you put it and then again rub it. So child will not get the shivering. And this
सादा पोता मुकवाना ने
and
sponge
तुरंत
करता
साफ
है
कराना. And this has this works excellent in my clinical practice.
Yes,
Yeah.
but the though data says that
Yeah.
there is no definite advantage of tapis sponging. But most biggest advantage is you keep the mother busy in doing something so that she doesn't do much anything. So it should make the child comfortable, should not make child to shiver more, right? Or make them cry to increase the metabolic needs. That's why if it is child is comfortable, enjoying, then we do it. Otherwise, no.
And in winter, use lukewarm water also. It's not that you require.
That's what we
yeah,
say to make the child comfortable.
comfortable. Yeah. So it's
Okay.
very important. Yeah.
Fine. So hydration with clothings and air conditions. So thick. So there is there is a tub full of ice, and you put the child immerse into the water. That is it okay?
No, not at all. Any comment on cooling gel pads?
Gel pads, yeah. So these all are cooling agents to be used in hyperthermia if at all you want to use it, because external cooling is required. In that case, otherwise, no. Now, AC. કેટલું રાખવાનું રાખવાનું કે નહીં રાખવાનું? 26 to 20 Anybody more than this or less than this? So again, you have to say no fixed number, just to make the child comfortable. And when newborns, what we say is when you are comfortable, child is uncomfortable. Newborns, because that is the comfort level for us. That temperature is hypothermic for that. So if the child is comfortable, you may make it.
So actually, in a child who is less than 3 months or 6 months, and so when your child is AC and having fever, I think you have to rub your hands properly. And from the dorsum of the hand, you have to touch the feet, and then on the abdomen. So your abdomen should be warmer than your feet, and that temperature is going to be the most appropriate scientifically, because it will prevent the hypothermia. It will prevent the shivering also.
So suppose કોઈ કે બહુ જ કપડા પહેરાયા છે, લપેટી રાખ્યું એટલે હવે ટેમ્પરેચર 102 થઈ ગયું. Is it okay? Is it possible? With the over wrapping of the child,
Yes,
102.
we have to first unclothe the child.
No. The thing is, 102 is not acceptable with just because of clothes. So we say maybe 100, 100.5 fever is there, and child has been wrapped up. We say just remove it, keep it outside, then you measure.
In newborns, it is very much possible. Overwrapping
any
will
fever
cause,
is
it can
concerned.
be because of overwrapping.
Correct. Okay, UT colon. People are fond of using it. So it is alcohol again. So better to use for some other purpose rather than.
They are using the cooling agents. They are not the part of your measure. They are the cool. They will just cool the external skin. They will not. They are not going to reduce our core temperature.
So there is no role.
No role.
Very clear. Okay, fine. Now I think you answer. So our prescription should be paracetamol according to weight. Mention the strength of formulation, dose in ml, and always according to the weight, not the age, because we know that now we can be wrong. Plenty of fluid orally, decrease activity, tapis sponging, yes or no, clothing to be removed. What clothing? Maybe cotton clothes, lightly wore. Explain the warning signs and follow up SOS. This should be our prescription in that patient. So now rapid fire, almost I think we have covered. How aggressive should be there for febrile conversion, Angelica? No, because that doesn't really work. Choice of antipyretic in hyperreactive airway disease? No. Do we have data for that?
Yes, there has been some studies. I've read it in my asthma modules, but I cannot quote exact data, but it is there that it can cause flare up of asthma. Yes.
Majority of studies says there is no difference. They do not trigger asthma. Only exception if there is adult onset asthma, if there is history of urticaria, if there is family history in there, and if there is history of exercise-induced asthma. These are 4 situations where the ibuprofen can trigger asthma. Otherwise, by and large, there is no difference.
So there is some.
But we have to be safe. Why to give it here?
But there is a printed alert in some of the formulations. That's more dangerous because the parents will read it and come back.
Okay, hepatitis, we discussed. Because we think that paracetamol is more dangerous, so we use something else which is more dangerous. Now this is Paracetamol, prophylactic or SOS in WP based vaccine or AP based vaccine?
No. Means first you give the paracetamol, then you give the vaccine. Never ever. Because we want to have some swelling or pain at the site of the injection. That will recruit more of the dendritic cells. Now, when you are giving an antibiotic, you are nullifying your dendritic cell. And there the antigen presentation in the lymph node is going to be poor. So, not.
So that's what my second question is. Suppose if I give it prophylactic, what will it happen on the effect of the vaccine? It can have effect on a vaccine. Never pre-vaccination, never regular post-vaccination. Only if child is not comfortable and fever is very high grade, you can use it. Dengue, we discussed indication of antibiotics
In
along with
dengue,
fever.
you need to take care of the platelet, not only number, platelet function as well. All NSAID is going to do the platelet dysfunction. Paracetamol is the only drug which keeps the platelet function intact, and that's why it is paracetamol, not NSAID.
When will you give antibiotics? As soon as the fever is there.
Only when you're sure of the
Immunocompromised,
diagnosis.
agreed? Okay. Neutropenic.
Maybe in immunocompromised patient, yes, we can
So
consider.
neutropenic,
And-
anything you want to add? Yeah. Febrile neutropenia. As soon as child is having fever, take the blood culture and then start the antibiotics. And that's why a person on a chemotherapy, they ask them to measure properly. Slightest rise in temperature, they ask them to give the antibiotics. So now just rapidly, audience question, identify the errors. A 1 month old newborn brought with complaint of fever, high grade 1 to 2 days, GP prescribed, this GP is not general physician, general pediatricians. Prescribed paracetamol drops, brought back with a convulsion, shrill cry next day. What was an error? Correct. So age of the child to be considered, very important, more chances of. Second, 5 days old newborn with primary mother brought with complaints of fever, decreased urine output, weight loss, prescribed oral antibiotics and paracetamol. What the error? Residents, are you practicing? Then it's good. You're looking very young. Please. What's the error here? Okay, so dehydration. You are moderate than me. It goes beyond that dehydration, the hypernatremic dehydration. Okay,
Also-
fine. So missing the dehydration fever. Okay.
And there is no role of oral antibiotic in the newborns. It's whenever we give antibiotics, it's always IV antibiotics in general, except for
But not in
local.
this patient.
yeah, not in this patient, but in general.
So a previous patient, yes.
So my one question.
Yeah.
Really, this paracetamol drops work in newborn? What the literature says? It does not work. We give it, I also give it, but literature says PCM in newborn does not work.
Any reason, sir?
No, I don't.
Okay.
Newborn, 30 days.
Even I had to read this. I'll have to read. Interesting. Okay. Now who will answer? Okay. Second last table. 3-year-old child brought with fever high grade according to parents since 1 day. In view of high grade fever, insistence of parents advise investigation CBC and ESR. What was an error? What was an error?
Day one,
They
you
got
day one,
pressurized
there's no
because
need
of
to
the
investigate.
parents. They surrendered to
Yeah.
the pressure of parents. Okay. Never CBC
Never
on first day. Right? Except for malaria and dengue, epidemiology. Okay, last case. 5-month-old child, playful, brought with complaints of fever since 10 days every evening. Went to GP before coming to us, who advised list of investigation, bunch of medicines. So decided to come to us. When asked to document a fever, come back, thermometer reading showing 98.4, which was considered fever by the parents. What was an error? Absolutely, where the role of counseling comes. Right? So that is very important for us to make them understand why and when it is a fever and why we have to document. Now, one condition where fever monitoring is very, very, very diagnostic. A condition you will diagnose clinically just by monitoring the fever and the response to paracetamol. Fictitious fever, okay? Okay, I'll give you a case. 4-year-old child. Fever high grade persistent 6 days. Counts high total count, CRP more, ESR more, few rashes, lymph node. Can it be Soja? Soja or Kawasaki? How will you differentiate these two? Agreed. But response to paracetamol and pattern of fever. Pardon? So in Soja, fever will come down with or without antipyretic, at least to baseline once a day. Kawasaki will never come to baseline, even if you give paracetamol. So Kawasaki continuous hectic fever, that is the word. While Soja, there will be at least once a day, it will come down to the bottom.
And secondly, in Kawasaki, mucosal environment is there.
Yes.
In Soja, there is no mucosal environment. And in Kawasaki, usually a single lymph node is affected, where multiple lymph nodes, generalized lymphadenopathy is with Soja.
Agreed. So this was just because the session was on fever. I tried to, anyways. Thank you so much. Hope you enjoyed that. Thank you so much, my panelists, for wonderful interaction. Thank you all.
Thank you so much, Chetan Bhai, and all the esteemed panelists. So yesterday, my mom told me that at 83 years, even Amitabh Bachchan is doing the shoots. What should we say about Chetan Bhai?
So am I?
No, not at 83. What will you do at 83 years? That is what I am asking.
You
So
be
you-
there to see that what I'm doing.
I will be there. So going ahead with the next topic. I invite Dr. Vinay Asawa, who is consultant pediatrician at ILS Hospital, Howrah. Okay, sorry. I don't have. So I invite Dr. Bivan Saha, who is Secretary IAP UK. Sir, please, a warm welcome to you. He is joining us from beyond the boundaries from UK, and a very good morning to you, sir.
Hi, am I audible?
Yes, sir.
Okay, hello, hi. I think it's a very early morning for us. It's about 7 in the morning. I've been waiting I've been listening to this fever topic, which was quite mesmerizing from Chetan. Chetan, I have met in a number of meetings all over the country. Just a couple of lines on this, in the sense that we at IAP have been something that has been going on. This friendship and this collaboration has been going on for the last many years, in the sense that we started in 2023 when we incepted the concept about Beyond Borders, an IAP branch which is quite decently active outside the country, and the first one in Europe, basically. Currently, we have about 37 members, and it is growing on a day by day. When I think probably I will place this for everyone, but I think the inception was done by no other than my dear friend Dr. Ranjan Pejavar, and the concept was started quite before that by Dr. Santosh Stones. But when I took it up in 2023, started very in a small podium, and now it has grown to the extent that we have now developed an international fellowship program, which runs across between India and UK, and we employ and train about 5 to 6 doctors, depending on the number of vacancies each year. And we have signed a MOU with IIP last year when the IIP leadership, Dr. Mohan, Dr. Kalatkar, and Dr. Parekh came over to UK in September, and they visited the training. They spoke to our residents who are from all across the globe, basically. It's running quite well, and I think it is a testament to the work and bridging of gaps and sharing of knowledge and ideas between the East and the West. There is no end to learning, and we as a fraternity are growing day by day. I think the participation and the programs that we do on a regular basis is on the IIP, DIIP portal. And we as a team, we went to Pedicon Kolkata, I think, which was really a mesmerizing event, thanks to all the hard work by the team, led by none other than my dear Dada, Dr. Atunu Bhadra, who is, I'm sure he's here and on this session. And then just after Pedicon finished, sometime in March, he called me and said that, look, we are trying to get a remembering the Pedicon journey and trying to remember what we did in Pedicon. And this is probably the aftermath or the continuation of Pedicon Kolkata, which is across this 10 cities, to reach out to the world and to reach out to everyone to probably a reminiscence of what we did and what the extravagant sort of a mixture of education, culture, and of course culinary that Kolkata has shown. I'm sure this is going to grow, and all thanks to IIP West Bengal branch, IIP in general, and Halion to be the co-host for this wonderful program across the cities. We as an IIP UK have supported this, and I'm going to introduce Vedangshu, who will be speaking about this on a topic. So there is one representative from IIP UK who speaks, who gives a sort of a his or her experience in the field on a particular topic, and Vedangshu is will be next to take up the role and talk about antibiotic stewardship in PICU and the practices. There will be variations in practice, but our goal is probably for a better future, for a better child, and a better IIP. Thank you. So I'm going to introduce Vedangshu. Vedangshu is, Vedangshu, if you can put your camera on. Yeah, so Vedangshu is a consultant in Leicester. He is a PICU consultant in Leicester. He's done his graduation from Guwahati and post-graduation from PGI Chandigarh. He has a lot of hats. I'm not going to bore you with all that because I think he's on call today and he has to go for a handover in the next 40 minutes. So he's got a lot of educational roles, research roles, quality improvement roles, and he's a fantastic academician. So over to you, Vedangshu, to lead the next session. Thank you.
Good morning, everyone, and thank you, Vivanda, for that introduction. Yes, of course, I don't want to say much about myself as well and what am I doing, but always happy to help. And I was very patient in listening to the fever, but in an intensive care, or everyone comes in, everyone gets worried, give paracetamol. But those reminds me of as a trainee and how much discussion we used to have around when someone comes in with temperature and what would we do? What investigations would we do? What could be the differentials? So that really brushed up my memory. So thank you so much for that. Let me quickly share my slides and let me then ask you whether you can see it or not. Where is it? Can you see my slides?
Yeah, slides that can be seen, Vedanshu. Just check if they're moving.
Yeah.
Okay,
Did you see
yeah,
them
it's
moving?
Yes, yes. Please continue.
So good morning again. Yes, it's going to be 7:30 in the morning. So it was quite an early start. I was told it was about 6:30, and it was one of those nights I was on call and got many calls. Just the children, few children, they decided not to behave well. So just up all night. But I was kind of like quite interestingly waiting for this talk to happen. As you could see, the name of my topic is antibiotic stewardship in pediatric intensive care. But what I'll be going to do today is that not just discuss about antibiotics, but it's about how we make decisions in PICU in a setting where patients are vulnerable, deterioration is rapid, and uncertainty is high. So throughout this talk, I want to frame stewardship as a clinical approach to balancing early life-saving treatment with avoiding harm over time. So stewardship is often described as using antibiotics only when needed, and if needed, using the right antibiotic at the right dose via the right route and for the right duration of time. But in PICU, this definition needs expanding because in practice, we are not simply deciding whether to prescribe, we are deciding when to act, how early to act, and how to keep that decision appropriate over time. So stewardship for me is not just an individual prescription. It is a system level process that supports safe, consistent decision making. And that's the lens I will use through for the rest of my talk. Once we understand what stewardship is, the next question is, what does good stewardship look like in practice? These are the core principles, which is quite common to adults and children. Start antibiotic when there is a benefit, choose the right spectrum, choose the right dose correctly, choose a right and appropriate review time, preferably early, and stop or de-escalate when the need isn't there anymore. These principles apply everywhere, but in PICU they become quite difficult and challenging because both starting too late and continuing too long can cause harm. So rather than thinking of these as static rules, we should think of them as a dynamic process. And that process becomes even more complex when we consider children. In pediatrics, and particularly in PICU, the clinical environment is fundamentally different. Children, they often present with non-specific symptoms and has the potential to deteriorate rapidly, and early diagnostics are limited too. So decisions are often not made with certainty, but made despite uncertainty. At the same time, dosing is individualized, pathogens they could vary with age, and antibiotic exposure has long-term consequences. So stewardship in pediatrics is not simply about reducing antibiotic use, it is about carefully balancing early treatment to prevent harm today and appropriate use to prevent the harm tomorrow. Let me bring up a case scenario to describe this further. Oh, this is quite a familiar story in PICU. We get it all the time, good few times a week. A neonate with initial subtle signs, poor feeding, lethargy, instability. As you all know, this is quite generalized. They don't give us any specific clue. Then within hours, they progress. This particular baby, there's a progression in the respiratory distress. Perfusion became quite poor and collapsed. At this point, we don't have a diagnostic certainty. We don't have culture results. What we do have is a critically unwell child. So the response should be quite clear: resuscitate, investigate, and most crucially, do not delay antibiotics. This is where the PICU decision making differs. We are treating a risk without a confirmed diagnosis. But stewardship does not stop when we start antibiotics. I'm not going into the detail of what antibiotic have we used. I do understand that what we would use in the UK, there's quite a lot of variation from different trust to trust. I'm sure this is going to be different in practice in various parts of India as well. That's why I'm keeping it quite general, but details are in the slide. Once the infant stabilizes, the question changes. We move from do we need antibiotics to do we still need these antibiotics? At 24 to 48 hours, we actively review the clinical response, inflammatory markers, microbiology, and then we make a deliberate decision to stop, to narrow it down, to switch, or to continue. The key message here should be de-escalation is not stopping care. It is keeping care appropriate. The same principle applies across all genres of children as well. So this is a different scenario. It's a previously well 12-year-old girl child, initially presented with typical respiratory symptoms, but then progressive deterioration. By the time she arrives in the ED, she has clear markers of severe illness. And again, our question is the same. We need to make a decision early enough whether antibiotics are needed and started subsequently, and based on the severity and not waiting for microbiology. Despite all of this, she deteriorates further, needing escalation in her respiratory support from high flow nasal cannula oxygen therapy to CPAP, and then subsequently bilevel support. The key question here should be actually antibiotics are necessary, but they're not sufficient, because these started despite starting antibiotic very early. We don't see a response, and that's actually the normal trajectory. We see a response quite later on, and what works within that time frame is all auxiliary supports that we need to provide. So the next step becomes, how do we ensure treatment that remains appropriate? So this looks like a bit of a busy slide, but I'll summarize it for you all. But this slide brings everything actually together. In the early phase, recognition and timely antibiotics are critical, but stewardship is what happens next. At 24 to 72 hours, what we do is reassess, then refine, and then adjust our therapy. The comparison is very, very important. Delayed antibiotics has the potential to worsen the physiology, pathophysiology, and subsequently needing escalation in the support we are providing. Similarly, early antibiotics, we all know there are evidence, especially in patients with sepsis or sepsis kind of presentation, that it leads to a better outcome. So in severe infections, every hour matters. But at the same time, we also need to understand that every unnecessary day of antibiotics, it also matters. So this tension between early action and appropriate continuation is shaped by the PICU environment as well. So I'm sure we would all agree today that PICU is a high-risk environment. Why? Because we manage patients who are physiologically vulnerable, diagnostically complex, and prone to rapid deterioration. Across all these groups, the common feature is unpredictability. We often need to act before we are certain, and that is why early antibiotics are necessary. But also, why stewardship is critical, because uncertainty can lead to overtreatment if not reviewed. So, how do we structure this balance in practice? Start smart, then focus. It is a practical framework. Start smart means recognize risk early, initiate appropriate antibiotics, stabilize the patient. Then focus. That means review at 24, 72 hours, reassess the diagnosis, refine therapy, stop or narrow it down, or switch or continue. But the key concept here is that it's not a one-time decision. It's a continuous review loop. Start smart, protects immediate survival. Then focus, protects against downstream harm. But we just need to remember that this does not happen in isolation. Again, this seems like another busy slide, but just to summarize it, we have already spoken about start smart, then focus framework. But the key question is, where does this actually happen in a day-to-day practice? The first layer is always the bedside, where antibiotics are prescribed, they are reviewed, and continued or stopped. This is the point of highest impact and highest variability, because decisions are made under pressure based on incomplete information and often influenced by habit or perceived risk. At the point of prescribing, we should be quite explicit. Why are we starting antibiotics? What infection are we treating? When will we review this? This is what converts antibiotics from an open-ended treatment into a time-bound clinical decision-making. At the bedside, early treatment is appropriate when risk is high. We often start broad antibiotic therapy and act based on severity, but there is no certainty. This reflects exactly what we saw in both case scenarios as well, if you remember. But the most important part is what happens after the first prescription. Stewardship is not a single event. It is a series of small daily decisions. Does the child still look septic? Are we seeing improvement? Do we still need the spectrum? These are the questions we need to ask on a day-to-day basis when we do our bedside rounds or when we review our patients. And this is where the success of stewardships begins. But we also need to keep in mind that, like silently, it could fail as well. And most importantly, we need to acknowledge that most errors in PICU are not in starting antibiotics, but they are failing to stop, narrow, or switch at the right time. This is primarily because of the complex group of patients we see that brings in inertia. Oh, just continue for another day, oh, just covering in case. We don't exactly know sometimes what's going on. We just follow our probably what we call a gut feeling sometimes, without much evidence. And this is exactly what stewardship is designed to address. So at the bedside, stewardship is about early action when needed, but equally structured, active review every single day. Bedside decisions alone are not enough because this decision should not be made in isolation. This slide, it expands the model that we just discussed. And it also shows how stewardship becomes reliable when it is supported by a multidisciplinary system. Antibiotic decisions in PICU are rarely individual decisions, especially in the UK practice. They are shaped by multiple perspectives. They are informed by multiple data sources, and they are refined through shared decision-making process. At the center of this model is the multidisciplinary team. There are intensivists, there are nursing professionals, there are pharmacists, there are microbiologists, and there could be other allied healthcare professionals as well. What we need to remember is that these are not parallel inputs, they are interdependent roles. The intensivist brings overall clinical context and risk assessment. The nursing professionals, bedside nurses, they bring in trajectory, what is actually happening at the bedside. Pharmacy colleagues, they support dosing, toxicity, and drug optimization. And our microbiology colleagues, they support spectrum choice and de-escalation strategies. So stewardship decisions are therefore constructed within the team, not owned by a single prescriber. Surrounding the MDT are multiple sources of information: the microbiology results, inflammatory markers, imaging, patient factors, local epidemiology, available guidelines, or evidences if it's a very complex and a tricky patient. And sometimes it also means need for multidisciplinary team discussion outside of the scope of the hospital as well. In rare instances, we sometimes go out to national MDTs. So no single data point is definitive, but together they build confidence in decision making. This is where then focus phase becomes reliable. Decision to stop or narrow or switch or continue. These decisions are safer because we believe they are safer because they are shared, they are discussed, and they are revisited. The outer layer of this model is governance, and that plays a big role. And what do? We audit from time to time, we feedback. There are antimicrobial committees. We take help of them as well as and when it is needed. And there are infection prevention systems that actually runs on a day-to-day basis. This ensures stewardship is not dependent on individuals, but sustained as a system behavior. And most importantly, this only works in the right culture that we call to be psychologically safe, non-punitive, open to challenge. Hence, stewardship should feel like a learning system, not just surveillance. So if we bring this together, bedside decisions, it starts the process, the MDT refines and shares those decisions, and governance ensures consistency and learning over time. This is how we ensure the original antibiotic decision remains the right decision throughout the patient's journey. And that brings us back to the central principle of stewardship in pediatric intensive care. So I'll conclude with a simple message that early antibiotic saves life, but inappropriate antibiotics cause harm. The solution is not delay, it is structured review. In PICU setting, we are not deciding whether to start. We are just ensuring that the decision stays right over time. These are my references. And thank you for your patience. I'll be happy to take any questions.
Thank you. Thank you so much, sir. You gave us a very nice lesson that it's always you need to think before starting the antibiotic, but it's not the only thing. we need to choose wisely to start, but also when to stop, narrow down, switch, or continue the antibiotics. Such a nice message. Thank you so much.
Thank you.
Going ahead, we are having a unique session today, that is Pedicon journey. And for this Pedicon journey, to give us a brief about this, I'm inviting Dr. Atanu Bhadra. Dr. Atanu Bhadra, sir, majority of us knowing he was a treasurer in the last 2 years at Central IIP. And he was the chief organizing secretary at the Pedicon Kolkata. We witnessed it a large gathering and a huge success. So, sir.
Thank you. So actually it's a thank you journey on behalf of the Pedicon team and Central IIP. We thank all of you whose contribution to this Pedicon was very vital for all of us, because maximum number of faculties came from Gujarat, and some important persons like Dr. Abhay sir was very instrumental in the scientific and the action plan programs. Dr. Chetan, Dr. Sandeep Trivedi as the vice president. And of course, we had a cultural program where for the first time there was no professionals involved. And Dr. Nehal had gave this suggestion, and we had all pediatricians from across the country, from different states, participating in the cultural program on the inauguration. And that was the first. It was also an idea which originated from Gandhinagar, the IPA Pedicon. And Chetan is very humble. He didn't want to speak, but he was the organizing secretary of IPA. So Chetan, brand आपका था, हम लोग accept किया. So part of it.
Yes, at that time I was part of it, and this time Atnuda gave whole responsibility to me to coordinate with all the states.
So can we have a video there? Just. Yep. Sound.
From Gujarat, we had at present CIPEV, Dr. Divyang, me, then 2 more from Sabarkantha. Yeah, Dr. Viral Kavi and Dr. Jayesh.
It was really appreciated because they rehearsed for many days, and it was very difficult rehearsal because all the doctors were from different areas. So we had to go to Zoom. The whole practice and everything was Zoom. In fact, in 23, we had the same practice of a ramp show in a EB meeting. That was also done by Nehal, and that was also practiced in a Zoom. So COVID had given us many things, and I think Zoom was one of the things that we all got.
So another person who is having a एक बड़ी सी पहचान. So, and for me, he's a big brother. So, Dr. Sandeep Trivedi, a neonatologist and pediatrician in Sabarkantha, Idar, and also the CIAP West Zone Vice President. Sandeep bhai, please welcome to the stage.
Already all the things explained by the Atnu, by audio visual, in what is going in the Pedicon and how the success Pedicon 2026 with the efforts of Atnuda and teams. So big round of the claps to the for the Atnuda for the grand success of the Pedicon 2026. And another Pedicon journey, there is a presidential action plan, which is the most important part of the Pedicon 2026. Because our presidential vision, Dr. President Madam, Dr. Neelam Mohan Madam, President's action plan is was done during the Pedicon 2026 to strengthen the pediatric practice and also improvement into the child health, which is very helpful to all the pediatricians and all over the improvement child into the health. There is a 14 action plan. This is the first time in the history, Pedicon. There is a 14 action plan is launched during the Pedicon. And at that time, in each action plan, more than 60 pediatrician is trained by the across the Indian faculty, which are expert into the all the subjects. Slides. Please run the slide. There are 14 action plan. All are knowing about the action plan. Already at Ahmedabad branch, given 3 to 4 presidents action plan during this, and more action plan distributed to the Ahmedabad branch. And maximum action plan is given to our Ahmedabad branch across the India. So already 4 action plan is done, and 4 to 5 in pipeline, and 2 is also given the date by the Anlika and Chetan Bhai also. So there is a TOTs is gut and liver care module, strike module, immune module. Chetan Bhai is one of the writer of the immune module and chief scientific convener. Dr. Abhay Shah sir is the chief convener of the strike module. So Atnuda told maximum faculty from our Gujarat side in Pedicon 2026. And there is in all the modules written by the most of the Gujarat people are there in all the modules, and 3-4 modules is led by our stalwart Abhay Bhai, Chetan Bhai and all others. And also Dr. Nehal Ben, who is conducting the cultural program of the Pedicon 2026. And across the India, more than 700 pediatricians are already trained for the modules, and till now, 290 module already done across the India, and more than 12,000 pediatricians taken interested in module and participate in all the modules. So big round to the presidential action plan, and we are going further more and more module, and 2 modules is also in pipeline and already started dengue module and derma module. And nowadays another module is launched, A to Z module for the nutrition, and more 2 to 3 modules are another in the pipeline. So each and every Sunday and Saturday, there is a 7 to 8 action plan running across the India. Sometimes in journal, there is a 7 to 8 plan same day. In John also, in our West John, sometimes there is a 7 to 8 modules run across the West John on Sunday same time. So big round to the Dr. Neelam Mohal, and thank you very much Atnuda for grand success of the Pedicon 2026. Thank you.
So now, for taking ahead to the Pedicon journey, I invite Dr. Vinay Asawa, who is a consultant pediatrician in ILS Howrah, and he was holding a main post in the Pedicon, that is treasurer. So coming all the money and how to utilize those money was in his hand. He is at present Vice President of West Bengal Academy of Pediatrics and Chairperson of West Bengal Adolescent Health Academy. Faculty already in many of the national conferences. Very welcome, sir.
Good afternoon, everyone, and thank you for coming to this program. Warm greetings from West Bengal Academy of Pediatrics and Helian as well. So 2026 was a very important year for us. After 13 years, we got Pedicon, and after 15 years, we got a new government. So I'm still working because till the audit is complete, my work is still going on. So it was the most anticipated pediatric congress, and science, there was science leadership and cultural converge was there. Highest faculty participation ever, and super specialty experts, unmatched academic depth. There were more than 1700 faculty power. National and international participation was there. There was massive networking and professional exchanges of ideas and literature. 9,000 plus delegates were there in Pedicon 2026. 700 plus overseas experts. There were latest global practices and cross-border collaboration. There was a special UK delegation and participation from WHO, UNICEF, Government of India, and public health relevation was specially focused on. Then we had Dr. Neelam Mohan interviewing with Nikita Podwal, who was Miss India, for HPV prevention advocacy. Celebrity supported awareness and mass outreach was there. In the morning, we had an environmental walk. There was a tree plantation drive and sustainable conference vision. Many health camps were conducted throughout. Food support initiative was there. On the 19th, we gave food to more than 2,500 children. And social responsibility. So we had this project Palash Abha, a village in Palashdiha in Asansol. Dr. Atonu is very active in conducting various sorts of programs, nutrition programs, and then there is also a school. We have hired 2 teachers who are teaching these students. So we had Pedicon Idol as well. Cricket and sports event was there, and fellowship beyond academics. Doctors led inauguration. We didn't call the politicians. Multi-state dance by IAPNs. Presidential night for all delegates. And next we meet in Coimbatore, Pune, and then we'll decide. So now I think, can we connect to Dr. Yogesh Parekh?
We can see you. We're on the last.
Yeah,
page.
yeah.
Yeah.
Yes, Dr. Atnuda, hello.
Yogesh sir, as a secretary on the whole journey, he was helping us and giving us his advice. A few words before we transfer to the scientific one.
Yeah, yeah. Thank you, Atnuda, Dr. Vinay, and Dr. Sandeep, Dr. Chetan, and Dr. Manish and Ahmedabad team. So thank you and for this arranging whole program in the Ahmedabad city for the Gujarat, all the members of the AOP Ahmedabad and the AOP Gujarat. So we know the Pedicon is a very tough task every year, and our West Bengal team has given the very important role to host this Pedicon in year 2026, and that West Bengal team has fulfilled all our commitment and what was assured by them in our Pedicon allotment committee. So they have done wonderful job. Thank you very much, Dr. Atunda and team, for this event and great successful Pedicon at the Kolkata. Thank you. Yeah, Dr. Mitul, I'm seeing Mitul and Sandeep. Who are else are there? Yeah, Mitul. Yes. Thank you. Thank you.
Thank you so much, Yogesh sir. And thank you to all the stalwarts who made this Pedicon journey a successful journey. Now going ahead with the science, I invite for the session panel discussion on bone health in kids. Our moderator, Dr. Manish Mehta.
Dr. Atruda, I am leaving for the CME in the Chennai. Thank you for inviting.
Manish Bhai is currently a EB member in Central IIP. He was a EB colleague last year with me also. And he is a leading pediatrician in Ahmedabad in the Synergy Hospital. So welcome, Manish Bhai. I also invite our panelist, Dr. Shalmi Madam. Shalmi Madam, so she is a pediatric endocrinologist in Ahmedabad, and she was the pioneer in bringing the endocrinology in pediatric as a different area into Ahmedabad. Endo Kids, she is running since so many years and a very helpful to all the pediatricians in Ahmedabad for diagnosing and also treating the rare cases also. And Dr. Chirantap. Yeah. So Dr. Chirantap is pediatric endocrinologist. Recently started his practice, but now a well-known figure in all of us. So I invite both of them to the stage. And the last but not least, the panelist is me. So let's go ahead. I'm inviting myself. So let's go ahead and take, giving the stage to our moderator.
So coincidentally, it's a black panel. Yeah. So basically, if you say like weak bones are like bad friends, they won't support you when you need them the most. So here we are to discuss why we are supplementing. We are discussing so much on vitamin D supplements, calcium supplements in infants, in adolescent. So we'll try to highlight few things why these supplements are needed. What are special situations where you need to supplement this vitamin D and calcium for the rest of the life? So let us start discussing this. First, we have an audience question. So first, we have an audience question. Why do we supplement all the infants with vitamin D from first week of life till 1 year? What are the reasons? So what is the content of vitamin D in breast milk? It is only 20 to 80 IU per liter. Okay. And how much we are supplementing? 400. Requirement is 400 IU per day. One reason is breast milk is very less sufficient to provide vitamin D requirement. Second is most important, lack of exposure to sunlight. But still, I think sunlight exposure is lack for everyone. So that is one reason. Third is this is one of the most important reasons. There is a very rapid growth. There are two phases of pediatric age group where there is very rapid bone growth. One is infant and second is adolescent. These are the two stages of life where you need to have good vitamin D and calcium intake. So that is one reason. And fourth is we say pregnant women are also deficient in vitamin D. So they provide less store of vitamin D to infants also. So these are the four reasons why we are supplementing all the infants with vitamin D for the first year of life. So calcium, phosphorus and vitamin D supplements are needed mainly to contribute the optimal peak bone mass because they are the maximum, at this age, they are at the maximum risk to develop weak bones and future osteoporosis in adulthood. So to prevent future osteoporosis in adulthood, we need to supplements with them. So they say peak bone mass. So what is peak bone mass? Any faculty can answer. What is peak bone mass?
So Manish bhai, as you said, right, that I would add one more stage. You said pregnancy because the baby is still inside, right? So there are three main stages. One is the first year of life where a baby is just 50 centimeters. Maybe at the end of 1 year, the baby is 75 centimeters. The baby never grows this rapidly anytime. The second is puberty. So we always say that that is the time where 30 to 40% bone accrual happens. And you are kind of building the bone bank for later on in your life. Right? So that is the time when they hit the peak bone mass. And therefore, this is again a phase where you have to make sure your calcium vitamin D supplementation is adequate. So your bone health is preserved. And then the third is pregnancy, because again, a stage of double demand on the body. The mother is already deprived and now the baby is also acting as a parasite, right? So these three phases of life are a phase where we have to make sure that adequate amounts of calcium vitamin D are given. I would just like to add one more point. It is not just up to the age of 1 year, but even, a 5-year-old, an 8-year-old also needs vitamin D, because none of our food sources have vitamin D. So at least the RDA of vitamin D have to be given all across through the ages. You and me also should be taking vitamin D now.
Yes, so that we'll discuss later on, like what should be done to prevent vitamin D deficiency throughout the life. Okay, so there are 4 stages: intestinal absorption, bone accretion, bone resorption, and urinary excretion. At these 4 stages, we have to maintain the homeostasis of calcium and vitamin D in the body. They have changed the presentation. Can you load which I have loaded the presentation? Then I'll give you pen drive again. So, Dr. Chirantam, can you explain this slide, because this is very important slide. What is the pathophysiology of rickets? Why we develop these bone changes?
Yes, sir. So, to understand the pathophysiology of rickets, first of all, we must be aware about how vitamin D works. So, as we can see in the box, the main substrate from which vitamin D is produced is called 7-dehydrocholesterol. Then there is exposure to the UVB lights, and that converts into pre-vitamin D3. So now the exposure of UVB light, the nanometer at which the ultraviolet B rays reach a tropical country like India, it's very much different. So the timing of exposure to vitamin D, most of us feel that early morning sunshine is the best. But for a country like India, it is time between 11 AM to 2 PM. So સવારના 11 થી બપોરના 2 વાગ્યા સુધીમાં, if and depending on our skin tone, like most of us are wheatish, so roughly a duration of 30 minutes with almost entire body surface area exposed, that will give us adequate vitamin D without taking any pharmacological supplement, which practically, if we see, is impossible, not just for pediatrics, but even for adults like us. So that is why Madam said that vitamin D supplementation should be there throughout the life, because the prerequisite for UVB exposure, I don't think many of us can fulfill. Now, the first step after the vitamin D formation is the 25 hydroxylation, which will produce 25 hydroxy vitamin D, which is something that we measure in the biochemistry. So that is why that step is very important, that the level when we write vitamin D for any lab to do, that is the 25 hydroxy vitamin D which is performed. Then it comes the step wherein most of the pathogenesis lies. That is the 1-alpha hydroxylation of vitamin D. So we get 125 dihydroxy vitamin D, which is the active form, also referred to as calcitriol, that causes the intestinal calcium absorption, prevents the renal loss, and also causes the bone accretion. Now this active form of vitamin D is converted into the inactive form by CYP24, which produces the 24-25 dihydroxyvitamin D, which renders the calcitriol inactive. So these are the common steps in the pathway of activation of vitamin D. Now, most of the regulation of it occurs via the 1-alpha hydroxylase. So the procalcitonin, it causes the conversion, and the 1-alpha hydroxylase is its activity is increased by the parathyroid hormone, and it is decreased by FGF23. And those two lie at the center of development of vitamin D resistant rickets, either VDDR or hypophosphatemic rickets. So now, if after understanding the normal physiology, if we look at the pathogenesis, if there is deficiency of vitamin D, in that case, the PTH gets increased, which is called secondary hyperparathyroidism. It causes increase in absorption of calcium from intestine, but it also causes resorption from the bone, which causes hypocalcemia. And because of lack of calcium in the diet, it can cause to changes like rickets. What FGF23 does is it increases the phosphate excretion, again, which causes hypophosphatemia, which again lies at the center of pathology of rickets. So if we consider one mineral which is essential for development of rickets, rather than calcium, it is the phosphorus, because low phosphorus will be common finding in all the patients of rickets. Low calcium will suggest dietary insufficiency, and if it is normal calcium, then we should look for the resistant or refractory forms.
And most of the patients, when you get the blood work done, very rarely you will get a low calcium, right? So then you will say, okay, ma'am, calcium is normal, phosphorus is normal. How can the child be still rickety, right? It is because so much of bone resorption has happened, because our ultimate goal is to maintain normal serum calcium levels. So that happens at the cost of the bones, and therefore the bones become weak and osteoporotic, right? So normal calcium does not mean that the child cannot have rickets.
So, Dr. Nehal, can you just enumerate why hypocalcemia develops in humans and children? What are the common causes that we see?
Yeah, so as already my learned colleagues has mentioned, mainly the nutritional deficiency and then less exposure to sun, but also the supplementation which we generally give to the newborn, like vitamin D and calcium, if it is there, and improper feeding methods. Mother is thinking that there is a good enough milk, but it is not there, or the mother is deficient in the calcium. There may be because of the lower socioeconomic condition of the mother, the child is not eating well, there is malnutrition, and also the perinatal risk factors, they play a major role. When the child grows, then there is a toddler and a season comes of picky eating. So they choose what they want to eat and they choose what they don't want to eat. In these, many a times nutritious and those which are rich in the calcium and vitamin D, they are left behind. So this ultimately affect the child's prickly eating, that affect the child's nutrition status. So all the parameters, weight for age, height for age, weight for height, that all are hampered, and you see the growth, they are all wasted, stunted, and malnourished. So basically the daily recommended allowance that should be there in all the child, but when it is not there, all the calcium and all other minerals are also very less when they choose what to eat.
So in our part of country.
So just one thing that I will add, that it's not just undernutrition, even for overnutrition. If someone is obese and there is a lot of fat, because vitamin D is a fat soluble vitamin, fat is the site of destruction of vitamin D. So besides undernutrition, even overweight and obesity also is one of the factor that causes vitamin D deficiency and subsequently hypocalcemia. So all forms of malnutrition.
And say if somebody is taking calcium, but there is a period of increased demand like puberty, and you're not supplementing them with extra calcium, that can also cause hypocalcemia. Okay, big glass to doodh pive hai, but now your child is growing at 10 to 12 centimeter per year. So that is not enough, right? So increased demand, you have to give more supplemental calcium.
So what are the common vegetarian sources of calcium and vitamin D?
So vitamin D, practically no vegetarian sources of vitamin D. It is either, as Chirantab mentioned, sunlight or through oral supplementation. Calcium, I would say dairy is the main source of calcium, right? You say banana has a very poor source of calcium. So, તમે બે banana પણ ખડાઈ દો તો માંડ તમને 20 milligram calcium મળશે.
Even people think sitafal.
Ha. So I think I really rely on my dairy intake. 100 milligrams of milk is about 100 milligrams of calcium. So I think so all the dairy products should be focused on for your calcium intake. But again, if you take too much of that, you end up having anemia and constipation. So maybe sometimes if needed, that supplemental calcium has to be given.
Yeah, so milk, cheese, paneer, these are the major sources, and sometimes ragi also is a good source of calcium. Yeah. So they say almost 40 to 60% of the kids in all age group are deficient of calcium and vitamin D.
કેટલા બધા તો મોટા થયા છે ને તો દૂધ ભાવતું જ નથી ને દૂધ પીતો જ નથી, right?
So nowadays pediatrician also advise after 1 year milk is not at all an essential part of the diet. Apart from calcium, if we see there is no role of milk in otherwise for the diet, but yes, calcium for calcium, that is the only
and protein
source.
also.
Yeah.
Proteins also.
Yeah. So what are the common clinical manifestations we see in calcium vitamin D deficiency, Dr. Shalmi?
So remember, let us keep vitamin D right now for the absorption of calcium, right? So whenever there is a vitamin D deficiency, all the symptoms that arise are usually because of low calcium. Vitamin D is also responsible for absorption of phosphorus. So typically you will get low calcium, low phosphorus, right? Now, as I said, the body needs to maintain normal levels of serum calcium, and therefore a lot of bone resorption happens under the influence of PTH. So mainly, as we said, you develop your rickets, you develop your osteoporosis, osteomalacia. Especially in the COVID times, you have seen so many kids developing proximal myopathy. So they have stayed indoors for 2 years, and then you ask them, they're not able to climb the stairs also. They're not able to sit from the squatting to a standing position. So again, just supplementing them with vitamin D has improved. So much of proximal myopathy, irritability, not gaining adequate height, poor bone health, your height is not going to gain, right? Largely open frontanel, widened wrist, all those typical features of rickets are there. We often see kids presenting to us as hypocalcemic seizures, right? Because sometimes the calcium level goes so low, below the level of 7, the body is just overcompensating, and the child for the first time presents to us as hypocalcemic seizures. Once in a while, you can get a referral from a cardiologist friend that, okay, it's a dilated cardiomyopathy, and the reason for that is hypocalcemia and vitamin D deficiency, right? So I think calcium deficiency, the symptoms are spread all across the systems, and therefore evaluating the levels of that becomes very important even in unusual presentations.
Yeah, so dilated cardiomyopathy is very important. It is probably one of the only treatable cause of cardiomyopathy. So you cannot miss a patient with dilated cardiomyopathy to do a vitamin D and calcium level. So that is very important. Even if it is not the reason, supplementation of calcium sometimes helps.
Sometimes even a newborn presents to us with pain on handling, right? And it is just because the mother was so severely calcium vitamin D deprived that the child is already born with a severe vitamin D deficiency, and that can cause stress fractures itself. So again, difficult handling newborn, always make sure that, this portion is taken care of.
And here is also a window that you should advise mother also, lactating mother also, to take vitamin D and calcium supplements, because most of the mothers after delivery, they feel they don't need any supplements, but calcium vitamin D supplements are equally important after delivery also. So let us discuss these 2 different cases of rickets. This case 1, 18-month-old male child, delayed walking, bowing of legs is noticed since last 4 months, swelling of wrist noticed since last 3 months. There was prominent chest, no history of chronic diarrhea, fracture, recurrent vomiting, renal disease, or anticonvulsant use. Only motor milestones were delayed, other milestones were normal. Weight and height below 3rd percentile, frontal bossing was there. So all the clinical features of rickets are there. Investigation: calcium, phosphorus, vitamin D, all were low. Alkaline phosphatase was high, PTH was elevated, and X-ray shows all signs of rickets. This was case 1. Let us see another case. This 4-year-old male child with complaint of similar complaint, difficulty in walking, bowing of the legs, recurrent dental problems, short stature, delayed motor milestones. But this child had received multiple oral courses of vitamin D as well as injectable and calcium supplement, but there was no improvement. There was similar complaint in maternal uncle also, and height and weight below 3rd percentile. There are all features of rickets were there. But here investigation, calcium, PTH, vitamin D were normal. Phosphate was very low. Alkaline phosphatase was elevated, urine phosphate was high, and X-ray was suggestive of rickets. and showing bony deformities also. So, Dr. Nehal, let us focus on case 1 first. What is it and how will you manage this case?
Yeah. So, as all the presentation, also the clinical features you mentioned, and everything is suggestive of rickets. And so, our first diagnosis will be the classical rickets. For classical rickets, vitamin D deficiency, I would like to go for first diagnosis as the classical rickets, and we'll approach regarding that. So, for approaching regarding that, with vitamin D responding rickets. So that is the first differential diagnosis in the mind. So we will definitely give vitamin D first. Vitamin D at a dose of 60,000 units every weekly for at least 6 weeks. And then the daily maintenance therapy. Then we should look for its response. But don't leave only vitamin D. You should supplement with calcium. So vitamin D, if you are giving, give it with calcium, elemental calcium of 500 milligram per day, and that is to be continued for 3 to 6 months. Now you need to check for the response to therapy. When you check for the response to therapy, first comes the clinical response. So clinical response, whatever you are having as a manifestation of calcium deficiency rickets, the child will be improving first in few weeks. Then will be the biochemical response. So your serum alkaline phosphatase, which was high, that will go down. It will start reducing. And then you will have the radiological response. So then the radiological healing of the bones, you will get to see that will appear in 6 to 12 weeks. Your therapy is still continued 6 weeks of this calcium, vitamin D, and your calcium is still going on up to at least 3 months. Now, at this point, if you are not getting anything, think something else as a differential diagnosis.
So do you need to investigate all these cases? Like this is very common presentation in OPD. Though this is a severe form of vitamin D deficiency, but milder form, we are seeing many cases of rickets. So do we need to investigate all these?
Go clinically. When you are supplementing, this is any case of the rickets, you are going to do the same thing. Even if you are investigating or not investigating, you are suspecting it clinically, you have done an X-ray, it's a rickets, go supplement with the calcium and vitamin D, and then check the response clinically. If the baby is improving, definitely it's a classical rickets.
Many people supplement vitamin D in delayed dentition also. Like how much it is recommended? Like many people, like child comes with 12 months of age, 15 months of age, dentition not started, and they will supplement with high dose of vitamin D.
Not even with the delayed dentition, it is like normal dentition. 6 મહિનાનું બચ્ચું થયું, હવે મમરી ખવડાવી દો. So
yeah, so that is there, but sometimes we are supplementing throughout the first year of life, so that has somewhat reduced.
Yes.
But this is very common after 1 year of age of mother complains is still dentition has not started. Everyone will start with high dose of vitamin D. So is it recommended? Like it is required? How long you should wait for dentition?
So one thing, it's very important that we prefer not to use high dose vitamin D in kids less than 1 year, especially in kids less than 6 months, right? Because there is a high chance of nephrocalcinosis also. So we rather prefer to give a high maintenance, sometimes of 2,000 to 3,000 units per day, right? We often know that normal dentition can be delayed to 15 to 18 months also. So if there are no other signs of rickets or a calcium deficiency, maybe just supplement the child with a normal recommended dietary allowance and monitor the child, right?
Yeah, so at the max you can give 600 IU per day. You can continue 1 more year of vitamin D supplementation, but no need to give high dose of vitamin D. So Dr. Chirantap, let's go with case 2.
Can I just mention one thing before? So as ma'am said, we often do not do an adequate calcium supplementation, right? Now remember, our bones are all deprived of calcium. So the moment you give vitamin D, the bones are very hungry for calcium, and whatever calcium you're giving is all rushed into the bones, causing a paradoxical dip in the serum calcium levels, right? So please make sure that before you say that this is something which is not responding to vitamin D and calcium, make sure you have given adequate doses of calcium and vitamin D. That is one of the most common referrals to us. And the moment we give an adequate dose of calcium, vitamin D, the child starts getting better. So that first 6 weeks, make sure you're giving a proper calcium, maybe 50 to 75 milligram per kg per day, along with high maintenance of vitamin D. And if after 6 weeks you see zero improvement, then maybe you want to explore the other causes.
Yeah, so that comes to around 500 to 600 milligram of calcium. And our normal syrup contains how much? 5 ml contains elemental calcium. So total calcium is 250 milligram in most of the syrup, as far as I know. But so it's very high dose. So 2.5 ml twice a day will not suffice. So you need to calculate and give proper dose of calcium. Otherwise, whatever madam has said is perfectly true. Your calcium level will actually dip after starting the vitamin D. So Dr. Chirantam, that was another case of 4-year-old child presented with rickets. But here things were different. You have given vitamin D. Yeah.
So choice of stores, this is sorry, high dose of vitamin D versus high dose daily recommendation. In case of low calcium documented and low calcium, low vitamin D documented, or low vitamin D with rickets. Your choice.
So practically in my practice, I've stopped using high dose vitamin D for the last under the kids of age of 1 year now. What I do is I'll give a high maintenance dose of vitamin D, 2000 to 3000 units per day, along with a high dose of calcium. That is very important. So we do that.
We are now going away from this 60K.
Yes, yes. And again, if you have a documented low serum calcium, say your calcium is just 7, 6.5, sometimes you might want to give calcitriol for the first 5 to 7 days because your normal vitamin D is going to take some time to kick in. So if you want a rapid rise of blood sugar, give calcitriol not more than 7 days, and then your normal vitamin D levels will start working. So we do that. We give calcitriol for some time.
Yeah, so there are always two regimes. Yeah.
Low vitamin D. Then also you give high dose
On vitamin D.
So then maybe 1000 to 2000 units per day to take care of the deficiency, shift to the maintenance so the deficiency does not happen again.
For how long?
So 12
If there
weeks
is a
will be
low-
duration, ma'am.
12 weeks.
12 weeks for all patients with rickets, without rickets. If there is documented vitamin D
D low.
So that
deficiency,
slide will come.
correction will be
Treatment
12
of
weeks.
hypocalcium and vitamin D.
What about the creation of pump max? Because when you have to give daily for 3 months, it becomes difficult. Whereas you give mega dose for fix and then things are done with the child. Is there any other
So
issue?
anyways, you're going to take your calcium 3 times in a day, ideally 6 hourly, right? So vitamin D comes usually as drops, which are very easy to take also. And I've always seen in my practice that taking those weekly or 15 days, patients tend to forget. It's easy to remember a daily supplement, especially for our kids.
My experience is different. I feel Sunday supplement is.
So other than compliance, any difference?
So such a high dose of vitamin D that goes. So after 1 year, if you're treating a deficiency, you can give, but it causes a very high calcium and occasional risk of nephrocalcinosis also. So that is why gradually practice is shifting from giving high doses to daily maintenance. No, sir, it has a role. It has a role for ours also, right? So we can always take one shot every 15 days or one shot every monthly based on requirements. And even if our older kids, we can give these nano shots. It's just when you're treating those deficiencies, no, sometimes that becomes an issue.
So practically you can think like if there is a severe rickets, clinically obvious, better treat with mega dose. But if it is a mild rickets, where a clinical diagnosis of rickets, you can just continue with high dose of supplementation rather than giving mega doses. Yeah, Dr. Chirantap. So
Yes.
I'll show you the case history again.
So yes, here in contrast to the first case, what we can see is in history that recurrent dental problems, that is one pointer that goes against nutritional rickets. Then second thing is a positive family history. So similar complaint of it was noted in mama. And then the third thing is that multiple times vitamin D nano shots, booster doses were given, but still there is no improvement. So when these three clinical scenarios are present, we must always think of non-nutritional kind of rickets. Then we rely on these investigations. Now, because calcium, parathyroid hormone, and 25-hydroxy vitamin D are normal, so we can rule out the calcipinic form of rickets. So VDDR type 1, type 2, we can rule out with these investigations. One thing that I would like to do at this point would be serum creatinine, because renal rickets could also be one of the non-nutritional rickets. And then as we see, serum phosphorus is low, alkaline phosphatase is high, and urinary phosphate is elevated. So most likely the diagnosis is phosphopenic rickets, because X-ray changes of rickets are also seen. And when lower limb is affected more than upper limb, it is most likely going to be due to phosphate loss. Now, to confirm the diagnosis, we have two options. Either we can do FGF23. If the level is elevated, it confirms the diagnosis of X-linked familial hypophosphatemic rickets, or we can directly opt for genetics, in which case we can get the result of X-linked hypophosphatemia. The treatment of it is to give oral phosphate supplement in the dose 20 to 40 milligram per kg per day, but the half-life of phosphate is very short. So it should be given 4 times to 6 times per day. So single dose of 500 milligram of phosphorus will not yield any good to the patient. So it has to be frequent multiple divided doses for phosphorus. Along with that, active vitamin D, like Madam said, calcitriol, and the dose of it should be very small. So 20 nanogram per kg per day in a single dose should be given. So that will cause the 1-alpha hydroxylation to happen. It will inhibit the FGF23 mediated inhibition of 1-alpha hydroxylase and will cause improvement in the rickets. And we can monitor with serum phosphorus and alkaline phosphatase level as well as with the X-ray. So the first signs of healing will be visible again in 4 to 6 weeks for these forms. And an orthopedic evaluation should be done, because the deformity for resistant rickets is quite significant as compared to nutritional rickets.
So Dr. Shalmi, when will you think of this is not nutritional rickets? What are the other reasons where you will not respond, child will not respond to these vitamin D supplements?
Yeah, so as I said, you have a classical case of rickets, clinical rickets. You have given proper 3 months of adequate amount of calcium and vitamin D, and still there is no sign of healing on the X-ray. The alkaline phosphatase levels do not come down. And as Chirantab said, right, there is a history of dental issues. There is a family history. Now, family history also will get some subtle family history. Okay, mama ne thoda pag vadela che, mama ne thodi height ochi vadeli che. No, not like a very clinical florid rickets history could be there. Usually, if you see your nutritional rickets, kids are very chubby, happy going. Now, these kids are very irritable. They have failure to thrive. They could have some electrolyte anomalies. Genu valgum presenting at a later age, you always want to rule out the other forms of rickets rather than the nutritional rickets, right? So whenever your classical rickets has not responded to calcium vitamin D, then you start exploring the other causes. It could be a simple case of VDR1, which will very well be managed by giving calcium and calcitriol. But that is the time you start exploring the other causes.
Yeah, so VDR1 is vitamin D dependent rickets type 1, where there is no conversion of 25 hydroxy vitamin D to 125 dihydroxy vitamin D. Type 2 is where there is receptors are resistant. There are certain chronic renal disease, renal tubular acidosis, malabsorption syndrome. In all these conditions also, they want to respond to these oral vitamin D and calcium supplements. So these things you have to keep in mind when your child is not responding to your supplementation of oral vitamin D. But many of these will respond to high doses of vitamin D for a longer time or injectable forms of vitamin D. But the resistant vitamin D deficient rickets will not respond to any of these supplements. So these are the differentiating points that we saw. In calcipenic rickets, vitamin D level will be low, while in phosphopenic, which case we discussed, they will be normal. In PTH level, there will be very high nutritional rickets, while in resistant rickets, it will be normal. Response to vitamin D is good compared to that phosphopenic rickets. Family history, you may be present in phosphopenic rickets, and etiology, usually dietary deficiency in nutritional rickets. In that case, that is a genetic cause. So when to suspect, Dr. Nehal, when will you suspect this, as madam has already discussed, when will you suspect vitamin D resistant or dependent rickets? So these are the reasons: not responding to your vitamin D, poor weight gain, electrolyte disturbance, irritable child, and positive family history. Then we will suspect vitamin D resistant rickets. So this is the summary slide for supplementation of vitamin D and calcium by IAP in 2017. Dr. Nehal, can you just summarize this slide?
Yeah, so majority of the cases when we are having newborn period up to the infant, then preventive dose what we are giving is around 400 IU, and when beyond it, it is 600 IU. When you are going for the tolerable upper limit or a treatment, then go to the 1000 units per IU for the newborn period, but especially the premature. But when
these are reverse,
yeah, reverse.
There is a typing error. So treatment
So-
is tolerable limit and yeah.
Yeah, so go to the 1,000 only for the premature, and then for treating it is 1,000 up to the infant. After the infant age, you need to triple the dose. So 3,000 IU per day. Per day up to the infant age, and after 1 year it is 600 to 800 milligram per day. In treatment, maximum again newborn it is 200 for premature and 500 for infants, and beyond that around 600 to 800.
Yeah, so remember, in premature, you need very high supplements of calcium and vitamin D, because most of the people they prescribe calcium just in a random dose of 2.5 ml twice a day or 5 ml twice a day. So you need to calculate, because it is very common to have like hypocalcemia and rickets in a premature babies.
So there are often these syrups that come of the same brand, but say, for example, I don't know if, so say I take syrup Calcimax, that has 250 milligram in elemental calcium per 5 ml. If I take Calcimax P, it has 150 milligrams in 10 ml, right? So if you write somebody Calcimax P 2.5 ml, you're not practically giving anything. So, you know, all these small things also matter where you are giving your prescriptions.
Yes, so there comes the next slide. 2:1, we are discussing a lot about 2:1 calcium is to phosphorus. Can you just throw light something about that part?
So frankly speaking, for nutritional rickets, we do not matter much because we need to focus on calcium and vitamin D supplementation. We know there is adequate amount of phosphorus in the dairy products also. So that is all going to be taken care of. But remember, if you just talk of the bone, there are two things: calcium, phosphorus, and collagen. We're not talking about these disorders. So any deficiency of calcium and phosphorus is going to cause poor bone health. So that is why this ratio comes, that if you're given a ratio of 2:1, we're making sure that adequate, that calcium, phosphorus, that crystalline that forms is in an adequate amount, and that is going to strengthen your bone.
Yeah.
So most of our formulas that we use provide it in the 2:1 ratio.
Yes, but on the contrary, when we are treating VDDRs, if we give a formulation that has phosphorus in it, it causes PTH resistance.
Correct.
And the biochemistry will improve, but the radiography will not improve. So in that case, we only need pure calcium. It shouldn't be the 2:1 combination with phosphorus.
Yeah, so most of the companies, they come to us, first thing they will show is we have 2:1 calcium is to phosphorus. So just supplement with calcium, whether it is 2:1 is there
So
or not.
practically in rickets, we do not think of phosphorus. We just give, unless it's, then we have to give phosphorus. Otherwise, we'll just give them lots of calcium and vitamin D.
But madam, for the newborns, when we are supplementing with the vitamin D and calcium, the syrup which doesn't contain phosphorus, that is okay for the newborn
This is
period.
beyond 1
Yeah,
year.
beyond
age
1
that we
year.
are
So
discussing.
remember, up to infancy, the syrup which is containing phosphorus, that is needed.
Even magnesium, people are coming with, we have magnesium also. So what is its importance in routine cases of vitamin D deficiency?
Magnesium.
So, routinely, to no importance, but it is said that magnesium improves the sensitivity of PTH. So when there is hypocalcemia, we are giving so much calcium correction. Still, if there is no improvement, hypomagnesemia could be a hidden cause.
Yeah,
So
so
there are genetic defects where there is hypomagnesemia, and that interferes with PTH and
yeah,
calcium.
especially those who are coming with tetany or hypocalcemic seizure, and when child is not responding to your IV calcium, then you can think of giving magnesium and getting the reports done. So we are missing so many conditions to supplement vitamin D and calcium. We are treating all rickets and vitamin D deficiency, but there are conditions which require regular supplementation of this calcium and vitamin D. So let us discuss those conditions. We'll start with puberty and cerebral palsy. Dr. Nehal, can you just throw light, how will you supplement these kids and why do they require supplements, regular supplements?
Yeah, so puberty generally it's a bone, it's a growth period. So whenever there is growth, there is high demand of calcium and vitamin D. So that's why here the supplementation is required. And many of these studies that has been done for the total bone body mass and total bone body mass mineral density, they have seen 3 groups. One is only calcium supplementation, another is calcium with other mineral supplementation, and third is control group. So what observed was even the those group which are having calcium and the calcium with other multivitamin and zinc supplementation, they were better than the control group, but specifically in the total body bone area group, even the multivitamin and zinc supplemented group, only the calcium supplemented group was still better than the control group. So definitely a role of calcium supplementation during the period of puberty.
Yeah. So what are the things that we supplement during the puberty? One is your calcium, vitamin D. Second, anything else you should regularly supplement?
Regular balanced diet.
Yeah. Even iron.
Iron,
In girls,
iron.
like once they start, yeah.
And even after the girls start menstruating, we do give, like, what is my practice? 7 days of iron every month to prevent the blood loss anemia.
Yeah. To replace. Yeah.
And check for B12 also, because many of these adolescent girls, they are B12 deficient because they are even very pickly eater adolescent girls. So B12 also.
And about cerebral palsy.
Yeah, for cerebral palsy, because these children, they are not going anywhere. So there is decreased sunlight. They are not moving. They are taking anticonvulsants and feeding difficulties, mostly on the milk diet or less diet. So malnutrition also. So these children, they suffer from the osteopenia, fractures, and the mineral density, which will be bone mineral density, will be low with vitamin D deficiency. So they require the regular calcium and vitamin D supplementation, and these are the different doses, 700. So depending upon the age,
Roughly dose remains this. Yes. In all high risk condition, we'll discuss further high risk conditions.
I think this is cerebral palsy is one condition that is often ignored by us pediatricians also. કારણ કે એક વખત physio પાસે પહોંચી જાય ને એટલે પછી we don't pay attention to them, right? But there are so many kids who, just with giving adequate calcium vitamin D supplementation, have shown improvements to compliance in physio also. નહીંતર હાથ પકડવા જાય ને they start paining because there are stress fractures. There is so much of osteopenia and osteoporosis. So I think this is one subgroup that we have neglected a lot, and we should pay some more attention to them.
Yeah, at least we can prescribe vitamin D and calcium to them. That is what cerebral palsy.
There are so many risk factors.
So with anti-epileptics, I have seen many a times folic acid written, but not the calcium written. So that is where the calcium is needed.
Yeah, and Dr. Shalmi, about type 1 diabetes.
So I think just like any other kid, even our kids with type 1 diabetes do face vitamin D deficiency. We know that so many immunomodulator roles of vitamin D keep on coming every day, and people have postulated that a lot in type 1 also. But I think type 1 diabetes, people have also noticed a poor bone mineral density, and therefore again the doses remain the same as all through the age groups, whatever you're managing your deficiency or maintenance, but make sure, so rather than, let us not ignore the special situations and make sure everybody is getting their adequate amounts.
Yeah, we are talking a lot about bone mineral density. What is this bone mineral density?
So basically, એક ક્યુબ લઈએ અને એમાં કેટલું bone mineral content છે એ આપણે bone mineral density થી માપી શકીએ છે, right? So if you see a normal bone, the structure, if you compare that to an osteoporotic bone, porous થઈ ગયું છે હાડકું. So the amount of bone in that 1 cube of bone, 1 centimeter cube, is very less. Right now, there are multiple factors. It is the bone strength, your collagen. So your osteosis is imperfect. I will also have a poor BMD. You do a BMD in rickets, you do a BMD in juvenile osteoporosis. એ બધું low આવશે, right? So basically, it shows how strong your bone is. Now, for the younger kids, આપણી પાસે less than 5 year na data નથી. But 5 years to 18 years, we tend to use the Z scores. So again, we need to have age and sex match controls na data. અને અમદાવાદમાં બી એક કે બે જ મશીન્સમાં એ વસ્તુ થઈ શકે છે. So that basically shows how strong your bone is.
Yeah, so basically bone has mainly three things: calcium, phosphorus, and collagen. So to measure all these, there is bone mineral density. DEXA scan is there, which can measure your bone mineral density, which will require in very few conditions which are high risk for developing osteoporosis, that you need to monitor this bone mineral density in those kids.
But between the two that are shown in this study, calcium pharmacological versus milk, it was shown that both of them had similar result, but they recommended that pharmacological calcium was a better way because it did rapid correction and it is more cost effective than milk, surprisingly. But then in a later follow-up study, it was found that the effect of milk supplementation was prolonged, whereas that of pharmacological calcium supplementation was short-lived. So between the two, if you want rapid correction, pharmacological calcium should be preferred. But for a more prolonged impact on bone health, daily intake of roughly 200 ml of milk for patients with type 1 diabetes is also recommended now.
Okay. Dr. Shalmi, something about DMD and prolonged steroid use.
Yeah, so prolonged steroid use again can happen in nephrotic syndrome also, can happen in these conditions also, right? We know that steroids are known to cause osteoporosis, they're known to cause myopathy and muscle weakness also. So again, these are high risk patients where we have to make sure that the supplemental or maybe the treatment, the therapeutic dose of calcium and vitamin D are taken on a regular basis. Sometimes we often, do a regular BMD scan for these patients. So we know what the baseline is, and then every yearly we'll do one scan to see. Sometimes just getting an X-ray spine, because you will see those compression fractures. Khali compression fracture pan spine ma dekhai jai, that is also an indication of osteoporosis. So agar DEXA nathi, to simple X-ray spine karine pan tame identify kari shakso whether the child has osteoporosis or not.
Yeah, so DMD is almost like your cerebral palsy patient, where you need to supplement, you can improve the strength of muscles and bones also. Dr. Chirantap, in thalassemia and Turner syndrome.
Yes. So for thalassemia, because it's a chronic blood transfusion dependent condition, there is marrow expansion which causes thinning of the cortex. But if we do a DEXA scan, and like Madam said, if we check the Z score, it will be very low because DEXA is height dependent. Okay, because now most of the thal patients are have compromised growth, so their height is shorter. So when you see the Z score in the report, it will be -5, -6, and we'll be tempted to treat those patients. So important thing to remember is if there is any clinical history of fracture in that patient, and if on DEXA the BMD Z score is less than -2, then that is an indication to give bisphosphonate. For children, zolendronate should be given because it doesn't affect the growth. But for adults, we can shift to oral alendronate as well. And regular calcium and vitamin D supplementation, as for all these high-risk groups, should be given. Similarly, for Turner syndrome, again, girls with Turner syndrome are always short. So DEXA will always be misleading. So it must always depend on clinical history of fracture, if it is present or not. And then we should consider for extra supplementation. For Turner syndrome, when we give growth hormone or estrogen, that also causes improvement in the bone mineral density. So the actual treatment of Turner syndrome with estradiol and growth hormone, along with this calcium vitamin D supplementation, will cause prevention of fracture, and we might not need bisphosphonates in future.
So as Chirantap said, just getting a DEXA alone and getting scores below -2 is not enough in children. Children ma definition of osteoporosis एक है कि poor DEXA plus a fracture. It could be a vertebral compression fracture, अथवा तो upper limb na more than 2 fractures, अथवा lower limb na more than 1 fracture. तो ज આપણે કહી શકાય કે the child has osteoporosis and maybe a candidate for bisphosphonates. But eklu DEXA showing poor BMD is not osteoporosis.
Yeah, so take home message is in all these condition from tomorrow, start supplementing vitamin D and calcium, irrespective of their level of vitamin D and calcium. At least that much we can do, especially in cerebral palsy patient, thalassemia patient, which are our regular patients in our OPD, where we just prescribe routine drugs which are already continuing, but at least add them with vitamin D and calcium from tomorrow. So, Dr. Shalmi, what are the general guidelines? What your patients or parents will ask, like, what should I do to prevent vitamin D deficient calcium in my child? So what will be your advices? An older child, in a younger child?
So I think the basics always remain simple. 1 hour of vigorous to moderate physical activity along with being active throughout the day. Adequate intake of dairy. Now, there would be some kids who cannot tolerate dairy. So then make sure that they're getting their pharmacological supplementation of calcium. Vitamin D supplementation, ideally for all ages. Another reason why we don't prefer to give loading doses because we're worried about the toxicity also. તમે 6 વીકનું પ્રિસ્ક્રિપ્શન લખી આપ્યું પણ પેશન્ટ will keep on taking it. એક વખતે ઓર્થોનું પ્રિસ્ક્રિપ્શન આવ્યું તો એ 4 મહિનાથી ડેઈલી 60K લેતું હતું. So all these things also happen, right? So those daily maintenance, we have to be prepared for the worst. So daily maintenance is always better. Simple standing in patients of CP has known to improve the BMD. So that is the importance of exercise, right? So that should be done. And yes, if you have a kid of vitamin D deficiency, monitor them clinically. If required, do the blood work also to make sure that deficiency is taken care of.
Yeah. So just a few slides about vitamin B12, Dr. Nehal. What is the role of, like, how it affects your skeletal muscle growth, vitamin B12?
Yeah, so vitamin B12, we know most of the vegetarian diet, they are deficient into the vitamin B12. We get the pernicious anemia because of it. Mostly, sometimes the inborn errors of vitamin B12 transport mechanisms are there, which leads to vitamin B12 deficiency, malabsorption syndromes, nutritional deficiency, not getting enough vitamin B, and GI surgeries sometimes. These all can lead to vitamin B12 deficiency. Now, with the vitamin B12 deficiency, we get different types of symptoms. In general, there will be muscle weakness, fatigue, not want to do anything, no interest, and failure to thrive. But sometimes when it is prominent, you get the neurological manifestations, apathy, sometimes tremors, sometimes regression of the milestones, seizures also. And that will be supported by your hematological investigations. When you check for the vitamin B12 deficiency, the vitamin B12 will be low along with the macrocytic anemia, but it doesn't stop there. All the cell lines are affected and they are decreased. There will be leukopenia, there will be thrombocytopenia. So almost all the cell lines are affected with the B12 deficiency.
So, Dr. Shalmi, can you just explain this side? It's a bit complicated, not of
Yeah,
practical
even I
use,
didn't
but still.
understand much of it.
Yeah.
But what I would say is we all know that vitamin B12 is very important in the brain development, nerve myelination, and the DNA synthesis, right? And even studies have shown that kids who are chronically deficient of vitamin B12, when you give them B12, there is slight improvement in their growth in the first 6 to 12 months also, right? So that is why making sure that vitamin B12 sufficiency is there is very important. So directly growth માટે જવાબદાર નથી, but it makes the substrate and the environment ready for everything to work properly.
Yeah, so they say almost 25% of the children are already deficient with vitamin B12 with less than 100 picogram per ml level, and few have less than 21.8 also. So do you like vitamin D and calcium, do you advise vitamin B12 supplementation like to all kids?
Yeah, not to the all, not to all the kids, but yes, those who are anemic, they needs to be there. We just write an iron, but we forgot about the even iron with the folic acid is written, but we forget about vitamin B12. And sometimes what happens when we write iron and folic acid, the consumption of vitamin B12 occurs and the child throws deficiency of vitamin B12 and there will be neuronal regression which starts. So don't forget vitamin B12 whenever you are suspecting anemia and writing the.
So whenever there is nutrition anemia, obviously child is nutritionally affected. So it may not be possible that vitamin B12 level will be good and iron deficiency anemia will be there, which will be much more worse than iron level. So always supplement vitamin B12 with iron in a patient of nutritional anemia. So Dr. Chirantab, can you just describe the treatment of vitamin B12 deficiency?
Yes, so for macrocytic anemia, vitamin B12 should be given in dose of 500 microgram for infants or 1000 microgram for older children. There are two regimes. One, either you can give it daily orally for 3 months, or you can give it every day for a week, then every other day for the next week, 2 times a week for next week, then once a month, once a week, and then once in every 15 days for a month, and then once a month. So these two are the regime which are given in the guidelines. Whichever we want to follow, we can follow. What we do is we call our pediatrician friend and refer back the patient to them. So there.
So better to give that 3-month regime because that is very much complicated, the previous one. And those with neurological symptom,
yes,
you
so,
will,
for them, parenteral form of treatment, which is followed by oral maintenance therapy is given. If there are neurological symptoms, then for 6 months. If not, then for 3 months.
Yeah, perfect. So just one take-home message from all the panelists, Dr. Chirantab.
So I would say that regular calcium and vitamin D supplementation should be done for all the children, and when it is rickets, it's never over investigating. So if you are sure that this is not nutritional rickets, then it's no harm in doing further evaluation.
Yeah, and but at the same time, resistant rickets is less common. So if you do not have the availability and the facility to get the investigations, but it looks like a clear case of rickets, go ahead and treat. Make sure you're giving adequate doses of vitamin D along with calcium. see the child back at 1.5 months and at 3 months. If there are no signs of healing or no signs of improvement, right, make sure you investigate for all the other causes. And let us not forget our kids in the special situations. They need our more extra care and attention. So let's not forget writing calcium and vitamin D for them as well.
So everything is about calcium and vitamin D, but don't forget phosphorus when there is newborn, and don't forget vitamin B12 when you are giving treatment for nutritional anemia.
And don't forget physical exercise. That is the most important thing. You always advise your parents to have at least 40 minutes of physical exercise, play, outdoor play to all the kids. That will help to prevent your vitamin D deficiency. So thank you all the panelists. Like you have done justice to all the topic.
Dependent anemias, we must give calcium and vitamin D in regular maintenance dose to the patients, because it is said that the iron overload, it also impacts the PTH, parathyroid hormone. So if it is if the hematopoietic stem cell transplant is done, or if the child is on the hydroxyurea or those medicines, then it is not mandatory. But if it is a transfusion dependent case, we must always give. If it is a lactose intolerance case or someone who cannot consume milk, in those pharmacological calcium supplementation must be done.
Any particular product, calcium product or calcium formation for milk allergy or lactose intolerance?
So what we do is that it should be the calcium supplementation, and the dose must be calculated on basis of maintenance dose, and the strength that we formulation that we prescribe must be checked. So like madam said, that 300 milligram per 10 ml is one preparation, 82 milligram per 5 ml is another preparation, and 250 milligram per 5 ml is the third preparation which is available for children. So we must calculate based on 50 milligram per kg per day and then give it for maintenance dose. No.
No, no. No. So normal calcium, vitamin D, because they cannot take milk and they are more likely to develop hypocalcemia. That is why giving calcium from outside is recommended.
Can we give each and every patient of milk allergy?
So if they are not able to consume dairy, which is the main source of calcium, તમે રાગી લો, તમે bananas ખાઓ, પણ તો પણ એ તમારું, so maybe you can take a proper diet history, see how much calcium they're getting from their diet, and if that is not enough for that particular child, they will need supplementation pharmacologically.
Because this week there is a two patient, one is mother having the develop milk allergy during pregnancy and after pregnancy, and one people age of the almost 7 months having milk allergy.
Yeah, but in milk allergy, we are supplementing with either hydrolyzed formula or soya preparation, which is also milk. So rest of the things will be there other than protein, cow milk protein.
Calcium 45. So we can just calculate how much formula they're getting and whether the calcium is adequate or not.
Yeah. Soya milk to soya milk is easily available. Yeah, so બધાના ચહેરા જોઈને એવું લાગે છે કે હવે નિશ્ચલ સરના લેક્ચરની જરૂર છે. Some happiness is required. So please.
Thank you, Manish Bhai, for excellently moderating this session, and thank you, my co-panelists, Dr. Shalmi Madam and Dr. Chirantap, for giving a very nice explanation to all the questions. Can we have a video? Just a short video. So we are having West Zone Pedicon and Guj Neocon conference at Narayani Heights on 14, 15 and 16 August. So I welcome you all for registering to this mega scientific event. એ તમે બોલી ચલો. નિશ્ચલભાઈ બોલશે, yes. वो तो बोल ही गई. Okay. So, for taking this, અવાજ નથી આવી રહ્યો પણ. It's okay. So, for taking this science ahead, today we are going beyond the science because our own happiness is very much important. When we are happy, our patients will be happy, our patients' parents will be happy. For this, we have equations of happiness by none other Dr. Nishchal Bhatt. And do we need an introduction of him? A past president of Ahmedabad, a guide always doing something for us to be healthy, even in the adolescent, our mental wellness well-wisher. So, Nishchal bhai, all yours.
So back to back, two conferences are coming. First is 4th and 5th July, Respi IDCon, a national conference. 2 years back, we did amazing Respi IDCon and it was very well appreciated by every pediatricians of Ahmedabad, Gujarat and India. Same thing is going to repeat with much advanced version this time. So those who have not registered for Respi IDCon, I am requesting you to register at the earliest. At least request 3 or 4 of your friends from Ahmedabad and Gujarat to register for this. So we will have good number of people participating. All stalwarts of respiratory and ID chapter are coming to Ahmedabad to give us a basic things about respiratory infectious disease, and that is the 80% of the cases in our pediatric office practice. And second is definitely West Zone Pedicon that will happen at Narayani Heights on 14th, 15th and 16th of August. So register for that also. Okay, બહુ વખતથી બેઠા છીએ, 1 મિનિટ ઊભા થઈ જઈએ આપણે બધા. એક્સરસાઇઝ નથી કરવાની, એક્સરસાઇઝ નથી કરવાની. I would request કે હું જે કરું છું ને એને just observe કરજો, and I will request you to do it as fast as possible. Okay, you will meet one of any pediatrician, shake hand, see in the eyes and then walk away. અને બધા everyone has to go to meet at least 3 person. Just shake hand, see in the eyes and go ahead and come back to your seat fast. Move. Fatafat, go and meet 3 people at least. હા બધા હોલમાં આવી જાઓ પાછા. Okay, come back and sit at your place. મારો થોડો ઓડિયો વધારી શકાશે? So first 4 videos are of 3 idiots. જ્યારે જોઈએ ત્યારે એમ લાગે કે આ લોકો આમ વિચારીને કરતા હશે આ બધું એમ, પણ પછી ડીપ જઈએ ને તો ખબર પડે કે they must have thought a lot before doing it. Now, these are grown-up adults. These are infants, very young children, toddlers. Why children are so happy almost all the time, and when we grow up, we try to remain more serious and not remain happy naturally. What is the difference between a grown-up adult and a child? Amazing. They are curious one. She also said the same. We think a lot and they remain in present moment right now. So that is the basis of remaining happy. If you can maintain your status 80-90% of the time in the present moment, because this is the moment which we are living. Just હમણાં 11 વાગ્યા 14મી જૂન 2026 લાઈફમાં ક્યારેય નથી આવવાની. તો એ વખતે કંઈ થયું હોય ને, we keep on thinking, repeating in our mind and feel anxious. Children remain majority of the time in the present moment, and that is why they are almost always happy. કઈ બી પહેરાઈને સ્ટેજ પર ચડાઈ દો, they don't mind because people are watching, they are appreciating, so they are very happy about whatever they are wearing. So that is so let us see three equations of happiness. The first equation is, what is stress? How do you define stress? Feeling of discomfort. And you start feeling stress. Now, if we see the equation of stress, pressure upon resilience is equal to stress. Majority of the time we try to manage pressure which is outside of our comfort, outside of our control. So when the pressure is 100 and your resilience is 10, you feel 10 times more stress at that particular moment. If you increase your resilience to 20, it comes 5. And when you reach to 100 as a resilience, the stress becomes 1. And if you see, stress has an inverted bell-shaped curve. If you put the performance on the x-axis and pressure on the y-axis, whenever your pressure increases, your performance go up. But when you reach to a level where the pressure is pretty high, your performance starts dropping. So use stress is very important to function very powerfully in our day-to-day life. And that is why when we achieve something, we feel the maximum happiness during that time, not just sitting and leisure and spending time out. So if we see, understand the stress, it is not always bad. If you stay in eustress curve, your performance is pretty prick. See, like Respiratory Econ is coming now few days back. All the committee members are firing up to do many things at the same time. The science is becoming happening, the pharma is happening, and everything we do very fast. All organizers might have felt the same thing. Ajay, when we are going to present this, we all were really gear up preparing for last maybe 1 week. So workload, responsibilities, deadlines, emergencies and expectations, but resilience is very critical. Last panel has discussed the same thing. Physical health, mental health, coping skills, support and mindset. If we develop this resilience and reach to 100, no stress will cause stress to us. We can be much more better in maintaining this. So we must work on resilience. And I always say a SMART acronym to increase our resilience. SMART, S is sleep. Regular adequate sleep between 11 p.m. to 5 a.m. or 6 p.m. This is the best time to sleep. Majority of our body regenerates between 11 p.m. to 3 a.m. So this is the time. I sleep 8 hours, but from 3 a.m. to 11 a.m. does not help me. So regular sleep time is very critical. Second, meals. We all know good balanced diet is very critical to maintain our physical health. The A is activity. Create at least 30-40 minutes of regular exercise. But many a times when we meet children of 8, 9, 10th, 11th and 12th standard, they don't have that much time to do 45 minutes of continuous exercise. Then we can divide it into 10 minutes of small aliquots. Or our routine day-to-day life, we can add something like every patient you get up and examine the child, you come back and sit. Every time there is an exercise which is going on. Every 15 minutes, you do a just general round of your hospital, come back and start examining the patient. Staff પણ alert થઈ જશે, થોડું કંઈ કરશે તો you can give few instructions to them and things will start working properly. Routine day-to-day life, જ્યારે બી વોશરૂમમાંથી બહાર આવ્યા અને 5 ઉઠક બેઠક કરી લીધી, that becomes a routine, regular, small aliquots of exercise which will add lot of physical health. કારણ કે happiness જો physical health નહીં હોય તો કોઈ કામની જ નથી, because it is not going to stay with us. So that is very important. Mental health, coping skill and mindset has lot of to do with the R of SMART. R is relaxation techniques. આપણે એવું વિચારતા હોઈએ કે રિલેક્સેશન તો 60 વર્ષ પછી થાય, એ પહેલા ના થાય, which is not the true. We have to start practicing various forms of maybe meditation, maybe relaxation, maybe breathing exercises, maybe small kind of some activities so that our mind starts getting relaxed. And I am telling it to my parents of teenager boys and girls. When we were young, the life used to change every 20 years. The parents, their life changed every 10 years. But for our children, life is going to change every 5 years. Because rapid change is happening. If they are not mentally strong because of use of these relaxation techniques, 100% they will not be able to cope any kind of stress. And that is what we are seeing right now, because our children are not resilient to handle this pressure of schools, exams, as well as college and the life. So resilience can be created. And T is avoid triggers which goes against all these things. Sleep, your meals, activities and relaxations, and then you will become much more resilient so that you can be at one in stress in any situations. So a resilient person will have a capacity to handle changes or adversities, show optimal display of emotions, manage stress appropriately, have ability to choose from options, can forgive self and others without distress, assertive in doing things and able to achieve target, and manage anger and emotional disturbances well. These are the signs of a resilient person. So go back, think about it, how resilient you are. કે નાનું મોટું કંઈ થાય ને સ્ટ્રેસમાં આવી જાય, પરસેવો થઈ જાય, ગુસ્સો થઈ જાય. You cannot manage many things at a time. Sometimes you start feeling real upset, anger. These all are signs of non-resilient person. So work on yourself. Increase resistance by using SMART, and definitely that will help you a lot. Now, second equation is very, very important. Actually, this requires at least 2 hours of interaction, but I'll try to complete in many 5 to 7 minutes. And that is E plus R is equal to O. In this, E is event, R is response, and O is outcome. Almost 95 to 99% of the time, we blame events happening in our life about our unhappiness, stress, and anxiety and unhappiness. Like many events, 12 June hamna જ ગઈ, and there was a plane crash happened there. But for maybe next 3 months, whenever we were supposed to travel by air, we started feeling anxiety about, अरे crash तो नहीं थी है. That was event which was out of our control. Many a times we drive, there is a crossroad, daily there is a traffic jam, but that traffic jam is out of our control. But 90% of the time we blame traffic for our anxiety. One of the staff member comes always late, and I started feeling angry. Now he coming late is not in my control, but even though I blame him for my anger. So majority of the time we blame external events for our anxiety, whereas the power lies in our response. If our response to every event is a calculated, thoughtful, very good, then the outcome can be very, very positive each and every time. I'll just give you the glimpse and the taste of how this is handled. So ability to respond every situation in a way so that I can be happy and powerful every time. As if I am just asking you, you are sitting, you are driving through a crossroad, the red light, green light is not working, there is no police, and there is a crisscross of traffic at that moment, and you are stuck in your car, and there is no way you can move. Routinely, if you are in this situation, આપણે શું કરતા હોઈએ commonly? બેઠા બેઠા ગાળો આપતા હોઈએ. હવે just listen to yourself. ગાડીમાં બેઠા છીએ, we are in the AC, glasses are closed, we speak foul language, who will hear? હું જ સાંભળવાનો છું. Toy we speak, we start honking immediately. જોશથી. What else we can do when we are stuck in this situation? Amazing thing. Very few people can think like that. I come out, if I have a driver, and I try to manage the traffic immediately. नहीं तो આપણે બેઠા બેઠા પોલીસને ગાળો આપ્યા કરીએ. That is the amazing thing, the last thing that everyone should start thinking. What else we can do rather than getting anxious about it? I can communicate and complete my phone calls. What else can we do? Listen to music. I have never experienced my car's AC because હું driving માં હું એક જગ્યાથી બીજા પહોંચવામાં. I start listening music. I start enjoying that. What else we can do? Like હું જાતે ડ્રાઈવ કરું છું, નીચે ઉતરી શકું એમ નથી, કારણ કે ટ્રાફિકમાં પછી મારી ગાડી વચ્ચોવચ પડી રહેશે. હું બીજું શું કરી શકું? Amazing. પછી what else? Talk to. Yeah, you can communicate, complete communication. See what active, we can call police, 100 number પર ફોન કરીને ઇન્ફોર્મ કરી શકાય, FM ને ઇન્ફોર્મ કરી શકાય. See, one situation you have 10 different options to respond, but 90% of the time we respond in the same way every time, either honking or using foul language. This happens in everyday situation of our life. If my son is like every time angry, I'll shout at him. But that is not the way every time I should communicate. I should go back, think about 10 things why he is doing this, what I am not providing, or what else I can do. So R is the ability to respond every situation in a different way. So there are only 3 responses we have any control over. If we just think, where do our emotions lie? આપણી લાગણીઓ ક્યાં રહે છે? હા, આપણી અંદર ક્યાં? માઇન્ડ. હવે ખબર નહીં, બ્રેનમાં તો we know there are synapses, there are cells, there are blood, Where do our emotions lie? શું બોલ્યા? Our thinking process. Whose thinking process creates your emotions? Your own. But 90% of time આપણે કેવી રીતે જીવતા હોઈએ? તે આવું કર્યું તો દુઃખ તો થાય જ ને, તે આવું કર્યું તો ગુસ્સો તો આવે જ ને, તે આવું કર્યું તો મને હર્ટ તો ફીલ થાય જ ને. We live our life like that, and we are dependent on people's attitude and behavior to feel happy about it. That is not the case. Just think about it. So we only have three response. The first is my thoughts. My thoughts creates my feelings. Very clear. જો એ મગજમાં હશે ને, then I have power to create good thoughts every moment in a very bad situation also. Now my thoughts creates images, because majority of the time we all think in images. That creates behavior. My thoughts creates images, my images creates behavior, my ongoing behavior creates my habits creates my personality, and my personality creates my destination. So if I can take care of my thinking moment by moment, that is awareness, that is meditation. I can create my destination just by changing the way I think about the life. But everyone think that વિચારો તો એમ જ આવે છે, તો હું થોડો ક્રિએટ કરું છું. લાઈક એક જ સિચ્યુએશનમાં ધારો કે ટ્રાફિકના 4 રસ્તા પર હું ગાડીમાં છું, હું એક અલગ રીતે બિહેવ કરું છું. The other person is stuck in the traffic, he behaves in a very different way. Like Dr. Bharat Bhai is stuck, he behaves in a different way. So what creates how I think in a particular situation? દરેકના વિચારો જુદા જુદા છે, પણ એ અલગ અલગ વિચારો ક્રિએટ કેવી રીતે થતા હોય છે? રાજેશ નો વિચાર અલગ હશે કોઈ પણ પરિસ્થિતિમાં, મારો વિચાર અલગ હશે. Why there is a difference? કોણ બોલ્યું? Amazing. The first is, it's my past experiences which creates my thinking process. In a way my belief system is created. So second reason is my belief system. સાથે respectfully જ વાત કરવી જોઈએ. That is my belief system. If he does not talk with me respectfully, I'll get hurt. I have created that belief system. That is not the truth. That is not the eternal sachai. Sometimes he is in a not good mood, he might react somewhere. That is not the eternal truth. But think about it. My thinking is always created by my past experiences. Second, my belief system. And third important thing which is created in last 20 years is my current level of information. Lots of negative information comes through social media to me that really creates how I think in a particular situation. Like COVID, we all know those who keep on continuing, numbers of death actually went faster than those who were not thinking about it. So my current level of information creates how I think. How can I change that? To add many positive inputs in my life. Daily reading of maybe 10 pages of a very good book, while traveling from one place to another in your car, creating a very good podcast list and listening to them. Like-minded people, you start meeting them again and again, and that creates lot of positive way in which I can change the way I think in any situation. Now, my thinking affects where? મારા વિચારોની અસર ક્યાં ક્યાં થાય છે? My thinking will impact first where? First, my thinking. Before that, we started emotions. So my thinking creates my feelings. We have to be very clear about it. It is not the circumstances, it is not the people, it is not the situation which creates my feeling. That how I think about it creates my feeling. Second, definitely it creates my physical health, because psychosomatic, we know 70-80% of the disease created by human body is done by my thoughts, my feelings. It also impacts my relationships, because how I think about X person will create the way I behave with that person. Like if I have some grudges with Manish Mehta, my body language, my words, my way of being will be very different when we will meet each other, which will create lot of distance between us. But if I change the way I think about that person, the relationship will change. There is no point the other person badla who relationship badlau, that will not happen. And last, my thinking creates my universe, because આપણે આપણા વિચારોમાં જ જીવીએ છીએ. It creates my experience of life. So my thinking creates lots of, everything is dependent on that thinking only. ચિરંતનભાઈ મજામાં? બહુ વખત અમે લોકો સાથે કામ કરીએ છીએ. We do a lot of work together in many workshops. I don't find your attire attractive. તમે બહુ લૂઝ આવતા હો છો. કપડાના ભાન નથી પડતા તમને જરાય. કેમ આવી રીતે ફરો છો? I have said this to Chirantap in front of everyone. How he would have felt about it? Bad, offended, hurt, anything other response? ગુસ્સો બહાર મળવા દો. આઈ બને, આઈ બની, હા. Then you have failed the E plus R is equal to O equation. It is not what I said to him will create this kind of emotions. When I have stopped talking to him, what he will think inside of himself will create his emotions. Think about it. What else he can think about this? First is, નિશ્ચલ ભાઈ તો મળે ને ત્યારે આવું બોલતા હોય છે, એલ ફેલ બોલે છે, એમને ભાન જ નથી પડતું. So you don't feel hurt about it. Or there are two ways. Either if he is really doubtful about his attire, he will think, yaar ha સાહેબે observe કર્યું છે ને તો કંઈક તો હશે, I should do some improvement in my attire. Or if he is confident about my attire, I am the best always, will not make any difference. So it is not someone who speaks to you creates emotions in your mind. એમના બોલ્યા પછી what you start thinking in your mind creates your emotions. So 100% all emotions are created by me, myself, no one else creates that emotions. If this comes very clear in your mind, you are emotionally independent person and very powerful. Nothing outside of you can create any emotional turmoil anywhere in the world, because then you start catching yourself કે જો કોઈએ મને કંઈ કીધું કે આ પેટ બહુ વધ્યું છે, અને જો મને ખરેખર એવું લાગતું હોય કે પેટ બહુ વધ્યું છે, તો I should thank him and start working rather than shouting at me કે તને હિંમત કેવી થઈ આવી રીતે મને કહેવાની. And if I am confident, ના આટલું તો જોઈએ તો જ વ્યવસ્થિત દેખાય, then I am fine. બોલવા દો ને શું ફરક પડે છે એનાથી? કશો ફરક નથી પડતો. So create that emotional independence. Otherwise we live our life giving remote control of our mindset to people. પેલાએ બટન દબાયું ગુસ્સો, પેલાએ બટન દબાયું હર્ટ, પેલાએ બટન દબાયું દુખી, પેલાએ બટન દબાયું jealous. We live our life like this. કાલે આપણા નીલમ મોહન મેડમ એવું ફતવો બહાર પાડે કે all pediatricians should go in your clinic. Girl should wear a sari 24/7 all days, and a boy should wear jabbo and dhoti. આપણે બધા હડતાલ પર ઉતરી જઈએ કે આવું કેવું ચાલે એમ. એટલે when people do a physical dependency on us, we are not happy, but we are already emotionally dependent on people. કે એ સારું વ્યસન કરે ને તો મને આનંદ થાય, એ જો ખરાબ રીતે બોલે ને તો હું દુખી થઈ જાઉં. It is not the way. So this is second equation, E plus R is equal to O.
Tommy? Yes, come on in. How you doing? Good. 23rd and Broad. Yes, sir. Yes, sir. Let's go. How are you today? Doing good. So much to do. So much to do. Whoa, whoa, watch out! Whoa, that was close. How are you so calm and so friendly? This guy almost ruined your car and sent us to the hospital. Well, I'll tell you something, man. People are like garbage trucks. Really now, how's that? Well, they run around with garbage. They're full of disappointment, full of frustration, full of anger. And when the garbage piles up, they need a place to dump it on. And sometimes they'll dump it on you. But you know what? You don't take it personally. You just wave, smile, you wish them well, and you move on. Don't let their garbage spread to the people at work, at home, or on the streets. You love those who treat you right. You pray for those who don't. See, now life is 10% of what you make it. The other 90, it's how you take it.
80% of the time, Dublu, if the child is very thin, mother will start complaining, sir, everyone is telling me child is very thin, Sahib moto karo na. If your child is a little mota, everyone will tell your child is very mota, very mota, very mota. So forget what they are telling. Your child should be properly weighed as per the child's age. And this is what is. People have tendency of telling you something which will make you unhappy, because they are all piled up with all those unhappiness in them. So they will garbage on you. So don't worry about what people are telling it to you. So don't give away your power to others, which is very critical. We always have a choice about our attitude, and it starts from our thought. So life is all about choices. When we cut away all the junk, every situation is a choice. We choose how we react to the situation. We choose how people will affect our mood, because who creates my mood? I, from my thoughts. It's not the people or the circumstances or the situation. You will choose to be in a bad mood or in a good mood. Always, every time, anytime. We cannot change our past. We cannot change the way people act. We cannot change the inevitable. That is not in our control. Anytime, anywhere. The only thing that we have control over is our thoughts or our attitude for the life. So let's go to the last equation, and that is equation 3. Choose happiness always. The same situation, how can I be happy? How can I choose happiness in any situation? The first is accept. What is acceptance? If there is a rain which is going on, 80-90% of the people will start doing, I don't like rain. I wish it wasn't raining. My day would be better if it wasn't raining. My day is ruined. Every day is like this. જ્યારે બહાર નીકળું ત્યારે વરસાદ પડે, જ્યારે બહાર નીકળું ત્યારે તડકો હોય. No. What is acceptance? Yep, it is raining. What can I do now? There are 3, 4, 5, 6, 7, 8, 9, 10 options if I accept it fully. ઘરે બેસીને rain enjoy કરું. રેનકોટ પહેરીને જાઉં, છત્રીને લઈને જાઉં, રિક્ષામાં જાઉં, ગાડીમાં જાઉં, મીટિંગ પોસ્ટપોન કરું, ઝૂમ પર કરી દઉં. I have many options to do that if I have to go out in the rain. But if I'll start cribbing, I'll not think about these options any day, anytime. Second is adjust. Third is avoid. If things are happening repeatedly, શ્યામલ ચાર રસ્તા પાસે સતત ટ્રાફિક હોય ને હું શ્યામલ ચાર રસ્તા પાસે જાઉં, દુઃખી થવું, મારો પ્રોબ્લેમ છે. I should have changed the track. Avoid that, adjust that. And this is very important. Between stimulus and response, we must pause and choose our response. That makes every response very, very positive for myself. And the last equation is SOS. We all know in emergency SOS. Whenever you are not feeling good, just tell your brain to stop. And our brain listens to us only. Stop thinking and observe what is going on in the mind. What happened 5 minutes back, 10 minutes back, 1 hour back? So I'm not feeling well. And then switch. For a while, immediately switch to something else, maybe physical activity, music, dancing, reading, talking to someone, or create something in which you can switch very fast. Initially, this switch will happen maybe 3 કલાક પછી ખબર પડે કોઈ યાર 3 કલાકથી તો દુખી બેઠો છું. Gradually, when you start practicing, you will start catching yourself immediately. Yeah, something wrong is going on in the mind. I need to switch immediately. come back to center, restart thinking, and you will start living your life very powerfully. So what we want, we must start giving it to all. If I need peace, I need to give peace to people. If I need contribution, I need to start contributing to the people. If I need love, I have to give a lot of love to the people. Contrary does not happen. I keep on shouting on someone and expecting that he will give you or she will give you peace. Does not happen that way. So this is very, 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 very good video. Just listen it very carefully.
आपको एक बात बताऊं? Don't build walls, ladies and gentlemen. Build bridges. कौन कभी लगेगा ना आपको पता नहीं लगेगा. अपनी उस्तादी मत दिखाओ दूसरों. Don't remain in the world of egoism by cutting like I don't care, I don't care, I don't care. Don't do that. You never know when you need that same person. आपको कभी नहीं लगा था in the wildest of your dreams you may never have thought that this is the person whom I would need at this time in my life, and that time जोश में आके काट दिया था आदम से उसको. Never build walls, always build bridges. And you can only build bridges by friendship. You can only build bridges by forgiving. You can only build bridges by adjusting. You can only build bridges by letting go. You can only build bridges by giving up your akkad. अखड़ने से कभी ब्रिज नहीं बनता. अखड़ने से दीवारें बनती हैं. अखड़ो अखड़ की दीवारें मत बनाओ. एडजस्ट करके पुल बनाओ, ब्रिजेस बनाओ, क्योंकि उसी रास्ते कब चलना पड़ेगा पता नहीं होता.
So 3 equations of happiness. Work on the resilience, so the pressure can be handled very powerfully and you don't feel stress. Second, E plus R is equal to O. My response to every event creates outcome, and I always respond the way I think about that particular situation. And last equation is SOS. When you start feeling bad about yourself, observe and switch immediately.
Celebration of your blessings is happiness. The more and more I celebrate what I have in life, the manifestation of that is happiness. Man had called for a party and everybody had come and everybody were dancing and there was absolute excitement in the air and nobody knew for what this party was called. He called, so they all came and he looks the happiest person there. And he is enjoying, he is freaking out. So one person took a lot of hesitation and finally went on, is there any purpose behind this party? Yeah, you didn't know that? Morning, my Mercedes Benz met with a very bad accident. And it's completely damaged. Everybody stopped dancing. What? Mercedes Benz met with an accident, you called for a party. He said, no. Nothing happened to the driver. I was driving. And the man paused for a moment and said, the Mercedes Benz is gone, and with money I will buy 10 more Mercedes Benz in my lifetime. But if my little finger is gone, nothing happened to the driver. And he told friends, let's understand, whether it is a 60 rupee toy car or a 60 lakh Mercedes Benz, what money can buy is called a toy. It's only a toy. And you should understand this. Rolls Royce is a 4 crore toy. Give it rightful place. Then you will enjoy. Otherwise you will not enjoy. Some of these buggers, have you seen? They will not remove the plastic cover from the seat at all. But seat will get dirty. I'm saying I'll give you a better solution. You make a plastic cover, cover yourself. Go everywhere inside the plastic cover. It's a toy. The more and more you learn to celebrate what you have in life, it's called happiness. Happiness is celebration of blessings in life.
Thank you so much.
A celebration where science, meets culture, where knowledge meets hospitality, and where the spirit of pediatrics comes alive. Welcome to Based on Pedicon and Guzniocon 2026, jointly organized by AOP Sabarkantha, AOP Gujarat, and NNF Gujarat at the magnificent Narayani Heights, Ahmedabad, a city that celebrates tradition with innovation. Welcome on the land of vibrant Garba, warm hospitality, rich heritage, and endless energy. Our venue, Narayani Heights, offers world-class conference facilities, luxurious hospitality, strategically located just minutes away from Ahmedabad International Airport, and well connected to major railway stations, designated to host more than 400 pediatricians from every corner of the nation. Come, experience the warmth of Gujarat, the excellence of Ahmedabad, hospitality of Sabarkantha, and the future of pediatric and neonatal care. Based on Pedicon and Gujarat Open 2026, 14th to 16th August 2026, Narayani Heights, Ahmedabad. We look forward to welcoming you to Gujarat.
Thank you so much, all the attendees. And for today's session, we had a great opening batsman with his colleagues. And at the last, we had all-rounder. So that's how we won today's match. And please join us for the lunch. Thank you so much.
So before we break for the day, can we have a photo session here? So I'm requesting all the speaker delegates, all the doctors to be on the stage. Let's have a photo session.